Good morning, everyone. So, although I see gradually people are coming in on a Sunday morning, but we do have some people who are motivated enough to start the next session. We had a really interesting session yesterday on prostate, non-metastatic, metastatic, and RCC. So today we do the bladder or the urothelial session, and we start with the non-metastatic and locally advanced one, and then going on to metastatic. We have a quiz for residents, although it was scheduled for 8:30 to 9, but we'll be doing it a little later because we are expecting some more residents to come after their Sunday morning slumber. So I would now like to invite Dr. Amandeep to take over and coordinate this session.
Yeah, thank you so much. Good morning, typical Sunday morning 9 a.m. audience. We'll wait for more people to join in, but nevertheless, we'll have to start on time. I'll invite the chairpersons for the session, Dr. Deepak Dangwal, who's a radiation oncologist from Mumbai, and Dr. Ankit Mishra, who's a uro-oncologist at Tata Memorial Hospital in Mumbai. The first session is about urothelial cancer, where we're dealing with the non-metastatic setting, so NMIBC and MIBC. We have a lineup of some talks from surgical oncology and also radiation oncology, and also by medical oncologists about some perioperative systemic therapy. I'll Ankit, yeah. And I'll ask Dr. Uday Chandan Khede, who's a uro-oncologist at Pune, to start off with the first talk. Thank you.
So good morning, everyone. I first thank you organizers for this opportunity. So today I will be presenting on this JCOG 1019 trial. Basically, this is a trial in NMIBC. So this trial is basically comparing active surveillance and versus intravesical BCG for high-grade T1 bladder cancer with negative second resection. So we all know, so T1 high-grade bladder cancer carries a significant challenge because owing to its aggressiveness and high risk of recurrence and progressions. So, and the treatment line for this T1 high-grade bladder cancer is always TURBT first, second doing an re-TURBT followed by giving an intravesical BCG, which includes both inductions and maintenance BCG for 3 years. But however, 50% of the patients would have PT0 residual tumors after TRBT. So the question arises whether do we still need to give BCG in this patient, because BCG also carries its own problem, like first is toxicity, second is availability and its cost. So this trial challenges the concept of routine over treatment. So the study objective of this trial was basically to compare active surveillance versus intravesical BCG on a population of T1 high grade on initial TRBT, which were PT0 on second TRBT and with negative cytology. So this was a phase 3 randomized multicentric trial which was conducted almost in 43 centers in Japan. So total patients which were included were 513. So after second TRBT, the lesions were PT0. So the total patients in this study were 263, which were randomized to two arms. First is active surveillance, which include 130 patients, and second in BCG, intravesical BCG arm, which includes 133 patients. So the BCG protocol here, it includes only the induction BCG, which include every weekly doses for 8 sessions, and no maintenance was given in these patients, which was against the standard protocol of treatment in T1 high-grade bladder cancer. So the primary endpoint was relapse-free survival rate, and the secondary endpoints were overall survival rate, metastatic-free survival rate, annual proportion of intravesical relapse-free survival, and adverse event. The median follow-up for the primary endpoints were 7 years, and follow-up was done with the help of blood investigations and urinary examinations, which were done at after 4th dose and 8th dose in case of BCG arm, and cystoscopy and cytology, the routine exam study, which is done every 3 monthly for 3 years, followed by 6 monthly in subsequent years. CT and MRI would be done yearly for 3 years, then subsequently every yearly. So this was well-structured study. So these were the baseline characteristics of patients in the study groups. So coming to the key results, first is relapse-free survival, so which was the primary outcome. We can see active surveillance was non-inferior to BCG with a hazard ratio of 0.69. So at 5 years, the relapse-free survival was almost 87% in active surveillance arm compared to BCG, which was 82%. So the take-home message, it was there was no compromise in oncological safety if you proceed with active surveillance. Coming to the cervical outcomes, the 5-year cervical outcomes in both arms were identical, which was around 92%, and metastasis-free survival was also comparable in both groups. Coming to the recurrence, which was slightly higher in intravesical, which was higher in the active surveillance group compared to intravesical BCG. So the almost it was 13 out of 15 participants in active surveillance arm, which was compared to BCG, it was only in 8 participants. So this was the subgroup analysis, which shows a non-inferiority of active surveillance compared to intravesical BCG, but there is a signal in like in age group of less than 65 years, we could see a higher recurrence. But this was not statistically significant because the sample size was small. So coming to the safety point of view, where the survival stands out most, the BCG would have 90% side adverse event compared to active surveillance, which is almost double. So this was a major clinical takeaway where active surveillance would have less toxicity. So coming to the clinical implications, so carefully selected patient can avoid BCG safely. It reduces toxicity, it reduces the cost, and it reduces the treatment burden. It was especially relevant in the current BCG shortage area, and it also supports very high risk adapted and individualized management. The limitations of this study was like it was limited to only one population, selected population, as compared to standard treatment care where we give a maintenance BCG to all high-risk patients. Here, the maintenance BCG was not given; only the induction course was given, which include 8 cycles. The study was only limited to Japanese cohort, and no enhanced cystoscopy was included. Only vital light cystoscopy was done in all patients. So to conclude, active surveillance is a valid and safer alternative to BCG in T1 high-grade patients with patients who have PT0 after re-TURBT. So this trial challenged a dogma and opened the door of de-escalation in uro-oncology. Thank you. There's a question.
We call the next speaker Dr. Gopal Sharma.
Yeah.
Very good data, especially in the avoidance of a drug.
Yeah.
Availability of BCG in India is not a problem in general.
It's a problem. So
It's a
that's
problem.
why the study was, the intention was mainly because of the current BCG shortage area. So this was a small subcohort like T1 high grade with PT0. Generally, the percentage of population would include around 50%. Currently, they have compared only one strain like Tokyo strain. And there was a globally shortage also that time when this study was carried out.
No, experience from the uro-oncologist here. In cities like Mumbai or Delhi or Calcutta, Chennai, big cities like that, they have a problem, or only smaller cities they have this problem?
No, it's a global problem. So,
Global problem.
Yeah, so nowadays we are shifting more towards like gem dosy because of the shortage of BCG.
So we'll have more of the discussion in the panel discussion forward. So I'd like to call
Thank
Dr.
you.
Gopal Sharma from New Delhi, who will be presenting the Potomac Albans Crest trial, the BLACA 16 Mosaic trial.
Thank you, sir, respected chairpersons and my dear colleagues. So, I'll be talking about the contrast of the previous study, and this Potomac trial is actually a series of 3 trials which were published together near about the same time. So, in this study, the primary testing drug was durvalumab, which was given in conjunction with BCG for patients with high-risk non-muscle invasive bladder cancer. This was a phase 3 open label randomized control trial. So what was the need for this study? As you already know that about 30 to 50% of patients with high-grade non-muscle invasive bladder cancer will develop recurrence after receiving TURBT and BCG. And also there is a significant proportion of risk of progression in these patients to muscle invasion. So, what was the biological rationale for this study? So, when a BCG is given to a patient, it leads to inflammation, and inflammation also leads to upregulation of PDL1, which actually leads to adaptive immunity. So, it was hypothesized that with giving uh, uh, these agents, PDL1 and PD1 inhibitors, this could synergize by inhibiting the adaptive immune response that is seen with BCG. So Potomac was a phase 3 trial, as I have already mentioned. It was conducted in 12 countries with 116 sites, and there were 3 groups. One group was given durvalumab along with BCG induction and maintenance. Maintenance was given for 2 years in the group 1, and this is important because I'll be comparing these other two trials. Group 2 was durvalumab with BCG induction only. Group 3 was BCG induction and maintenance only. So it had very specific inclusion and exclusion criteria. Patient should be 18 years or above, should not have received BCG, or he or she should have received BCG 3 years ago. Patient should have histological confirmed high risk TCC as per EAU. Patient should be fit, ECOG 01, and should have normal function. And it had exclusion criterias which were broadly classified as having contraindication to BCG or any contraindication to immunotherapy. A study had 2 endpoints. Primary endpoint was disease-free survival comparison within group 1. So group 1 is durvalumab plus induction and maintenance BCG for 2 years. Group 3 is comparison, in which patient received only BCG. And DFS for this study was defined as absence of high risk disease recurrence or death. Secondary endpoint was comparison of DFS in group 2 versus group 3. Group 2 here was durvalumab plus induction BCG. So this was the consort diagram for this study, and about this study enrolled about 1,000 patients. Median duration was 60.7 months, and treatment was completed by 53% of the patients in group 1 and 54% in group 3 patients. And this last line is very important, as this compares to other studies like ELBAN and CREST. This study had a large number of patients with papillary disease, and about 60% had patients with T1 disease. So this is the same table, and now this is the primary endpoint, disease-free survival. As you can see that there is a significant difference in hazard ratio for comparison of disease-free survival for group 1 versus group 3, which was about 32% reduction in disease-free survival for the primary endpoint. And the secondary endpoint was comparison between group 2 and group 3 for DFS. There was no difference between the two. And overall survival, there was no difference between the group 1 or group 3. And the side effect profile, obviously side effects were slightly higher in the combination group. About 21% patient had group grade 3 or 4 side effects in group 1 and 4% in group 3. There were no deaths attributed to treatment related adverse events. So finally, this is the last slide which I have put up here, which compares these three trials, Potomac, CREST and ELBAN trial. So in Potomac used durvalumab, CREST used sesanelib, which is a subcutaneously administered drug, and ELBAN used atezolizumab. So Potomac had 3 groups, as I've already explained. CREST had 2 groups in which they gave induction as well as long-term maintenance, whereas ELBAN had only short-term maintenance. That is, they gave maintenance of BCG for 1 year along with atezolizumab. So out of these 3 trials, this CREST and Potomac were positive trial, as they showed disease-free survival benefit for IO therapy. Now the ELBAN trial was negative, and there have been many reasons mentioned in literature why this trial was specifically negative. For one of the few reasons is that first, people have hypothesized that this atezolizumab is not that much effective. Second reason is that shorter duration of BCG maintenance in this trial was used. It could be one of the reason. So thank you regarding this study. I think I have one more study to present, so I'll just get on with it. So this is actually one of the surgical study in which it is called Mosaic or Dabla 16 study, and in this study compared retrosigmoid ileal conduit versus conventional ileal conduit. This was a initial feasibility study, and it compared 90-day post-operative complications as well. It was published in European Urology Open Science. So as surgeons, we already know that when we cross the ureter behind the sigmoid mesentery, it induces a bit of ischemia onto the left ureter. So it has been seen that left ureteric strictures are quite common in about 15% of the patients. Overall strictures are seen, and that too it is common on left side as compared to the right side. So there has been rationale for this retrosigmoid ileal conduit as seen in this diagram, in which surgeons can take a longer conduit, which is about 25 cm, and tunnel it behind the sigmoid mesentery, and instead of tunneling the left ureter, you can anastomose the left ureter to the ileum there. So it was hypothesized that this could lead to lower stricture rates. So this was the hypothesis, that the authors were testing in this study. So this was an open label randomized control trial, 1:1 allocation was done. It was conducted in a single country in Denmark at five major centers. So eligibility criteria were patients who were scheduled for robotic radical cystectomy with ileal conduit, and randomization was stratified as per the center and presence of hydronephrosis or hydroureter. So, as I have already explained regarding this, what was the intervention between in the control arm was conventional ileal conduit we already do, and mosaic was in which we take the ileal conduit and put it across the this sigmoid mesentery, and then instead of anastomosing, and instead of taking left ureter below the sigmoid mesentery, we anastomose it to the ileum there. So this is the consort diagram, and then this study had recruited 303 patients, and each arm had around 150 patients. So about 92% of the patients who were randomized to the treatment arm, that is retrosigmoid ileal conduit, were able to receive this treatment. There were no significant differences in between the perioperative outcomes between the two groups for any of the outcomes, and obviously resected part of the left ureter was longer as compared to the intervention arm. And this is the table showing the same perioperative and post-operative outcomes. This table 3 shows 90-day post-operative complications. There was no significant difference between the two groups. So basically it was an initial feasibility study in which authors were trying to see whether doing this retrosigmoid ileal conduit was possible or not, because the primary outcome for this study was to study the rate of strictures, but as the duration of follow-up was very small in this study, they could not convincingly say whether the stricture rate was low or not. So basically it was an initial feasibility study. There was no differences in the renal functional outcome as well in between the two groups, as quite evident from this table. So to conclude, retrosigmoid ileal conduit with RARC is technically feasible. Early post-operative, perioperative outcomes were similar, and further long-term results are needed to assess whether it could lead to the lower stricture rates on the left side or not. Thank you.
Any question? So I'd like to invite next speaker, Dr. Priyamvada
Thank
from TMH Mumbai. She'll be speaking on BART trial and Genitourinary.
Good morning, everyone. Thank you, organizers, for giving me this opportunity to speak about more advanced bladder cancers and the role of adjuvant radiotherapy in these. There are two abstracts that I'll be discussing. So, advanced bladder cancer is typically treated with this paradigm. We know this. Patients receive neoadjuvant chemotherapy for about a 5% OS benefit, followed by a radical cystectomy, and adjuvant immunotherapy for about a 6 to 8% OS benefit. Despite these, about 30 to 40% of the patients are expected to recur in the next 2 to 3 years. They can either recur in distant locations or locoregional or both. But locoregional recurrences in these patients are often an underappreciated problem. As you can see here, they are ugly, morbid, unsalvageable, and often lethal. And surprisingly, chemo doesn't impact the rate of locoregional control. So this data is from long-term outcomes of one of the landmark NACT trials, BA06, which showed that despite improvements in OS, locoregional control wasn't really wasn't really benefited with addition of chemo. That brings us to the first trial, bladder adjuvant radiotherapy, or the BART trial, clinical outcomes. This was presented by Dr. Vedang Murthy in the plenary session of ASTRO last year. This is a multicentric phase 3 trial from India done across 4 centers and led by Tata Memorial Center, Mumbai. Patients with high-risk bladder cancer who were post-radical cystectomy and pelvic lymph node dissection with certain pathological high-risk features like T3 or T4 disease, node positive or margin positive, less lymph node yield, or those downstage with NACT, were randomized to either observation, which was the standard at that time. There was no immunotherapy when the trial was conceived. And the other test arm was adjuvant radiotherapy, 50.4 gray to the pelvic lymph node and cystectomy bed. Primary endpoint was 2-year locoregional failure-free survival, and 153 patients were randomized. This is how radiotherapy was delivered in the trial. So lymph nodes, right from the common iliac to internal and external iliac, presacral and obturator stations were covered, and cystectomy bed was covered using standard contouring guidelines. IMRT and image guidance was mandatory for all the patients, and the stoma and ileal conduit was spared. On the right hand side, you can see a typical dose distribution. Cohort characteristics in this trial, so median age was about 57 years, which is little younger than the Western population. Most of the patients had locally advanced disease, so T3, T4 in more than 3/4, and node positivity in about 40%. About a quarter also had some variant component, and importantly, 91% received systemic chemotherapy, 70% received neoadjuvant, which was quite high. The primary endpoint, at a median follow-up of 47 months, 18% patients had a locoregional recurrence event, and resulting in a 2-year locoregional failure-free survival of 87% with radiation versus 76% with observation. This was statistically significant. Secondary endpoints were analyzed on per protocol basis, and roughly we saw a 12 to 15% improvement in DFS, bladder cancer specific survival, and overall survival, though the overall survival did not reach statistical significance. Subgroup analysis, so who benefited? There was a suggestion that the benefit of adjuvant radiotherapy was stronger in node positive disease and patients who had completed neoadjuvant chemotherapy. The tolerance, acute and late toxicity, this was reported in detail about 2 years back. So reassuringly, grade 3 or severe toxicities were quite low, less than 5%. All the patients were able to complete the planned course of radiation. Grade 2 side effects, about 20%, mostly bowel related like diarrhea, and late toxicity was similar, about 10% in both the arms. The second trial is done in a similar population. This is a phase 2 randomized trial from France. They also recruited pathological high-risk urothelial bladder cancers with similar high-risk features. It was a smaller trial, and randomization was 1:3 across observation, 22 patients, or adjuvant radiotherapy, 50 gray again, 58 patients, with a primary endpoint of pelvic recurrence-free survival. So comparing cohort characteristics, this was again quite similar to BAT trials, but NACT was in 70%, 60% of the patients. About 60% were node positive. Margin positivity rate was around 16%, and neobladder in a minority. Radiotherapy was started in a median of 14 weeks, or about 3 months from the surgery. And again, all patients were able to complete the planned dose without any toxicity related early terminations or gaps. Severe adverse effects, again quite low, less than 5%. So in the RT arm, one patient had a grade 4 intestinal obstruction due to disease progression, and another had a grade 3 obstruction at the ileal anastomosis, which was away from radiation field and was deemed unrelated. In observation arm, one instance of grade 3 ureteric stenosis, so quite low. Grade 2 or moderate side effects, about 35% in the radiation arm versus 9% in the observation arm. So GI side effects were more common in the radiotherapy arm, about 27%, and mostly diarrhea, constipation, or abdominal pain. And urinary side effects were mostly urinary frequency or urgency. Now, till date, there are 3 trials for adjuvant radiotherapy in high-risk MIBC cohorts. So these are the 3 trials. BART is the largest of them, followed by the Egyptian trial by Dr. Zaghloul, which was published 2 years back, and the French trial, which is smaller. Cohort characteristics are mostly similar in all the 3 trials, and the rate of chemo utilization is also quite high. Intervention similar 50 gray to the pelvic lymph nodes and cystectomy bed. All patients received IMRT, and probably that contributed to the low rate of adverse effects. The severe adverse effects were about 5%, and the moderate side effects were about 20 to 30%. So it may be safe to say that adjuvant pelvic IMRT 50 gray is okay to give, and this is not a surprise to radoms who give this dose regularly in other GI and gynecological malignancies. How to integrate this with adjuvant immunotherapy, because when these trials were going on, there was no standard of care adjuvant immunotherapy which is there today. So the outcomes from BART, if we see in context of the adjuvant IO trials, nivolumab or pembrolizumab, inclusion criteria has been quite similar. So high risk pathological features after surgery. 2-year loco-regional control in BART, the hazard ratio is 0.4, whereas we don't know the patterns of failure from IO trials. But DFS remarkably is consistent, 0.6 in all the 3 trials, although the IO trials were quite larger. And OS again quite similar, but they reached statistical significance in the nivolumab trial, and BART probably was unpowered to detect the translation of loco-regional benefit into overall survival. Side effects, if we see, RT did not cause any undue additional toxicity. So we are basically seeing the signal of similar magnitude of benefit at smaller toxicity and cost. So probably there is space to consider adjuvant radiotherapy in patients who are receiving adjuvant IO, and also those who do not have the adjuvant IO option available for any reason. Thank you so much.
So moving on, we'll call the next speaker, Dr. Prahlad Ilamarthi from Bengaluru. He'll be presenting 2 studies. Dr. Randeep will be giving the presentation on his behalf.
Thank you, chairpersons, and I had to fill up the shoes of Dr. Prahladi was not available. So the 2 abstracts which I have to present is related to chemoradiotherapy as a bladder preservation technique, and the one has been presented at ASMO, where nivolumab, the immunotherapy drug, has been combined to chemoradiation as a bladder preservation, and the second, pembrolizumab, is another immunotherapy drug. And the whole concept is that while we add chemotherapy to radiotherapy, the chemotherapy works as a radiosensitizer as well as it works as an anti-cancer drug. And while this mechanism is happening, there are few cells which also get systemically circulated, and there the immunotherapy may help to control these micrometastases while we are doing chemoradiation. The first study was nivolumab plus CTRT after maximal TURBT. Though the inclusion criteria in this trial was T2 to T4, but this was majorly a T2 trial. The standard CTRT cisplatin based was used, and in the experimental arm, that is the red box, nivolumab was combined, and there were 2 doses which were given before CTRT as a sensitizer, like we do it with head and neck cancers, and then nivolumab was continued after CTRT for 6 months. This was a phase 2 trial. The primary endpoint was loco-regional failure, and the secondary endpoints were the quality of life OS and bladder specific survivals. Majority, as I said, 90% in this trial are T2, and majority of them are TCC, but there were around 7% having squamous and mixed histology. 5% were having hydronephrosis, and most of them were able to undergo maximal TURBT. The secondary endpoint, that is bladder cancer failure-free survival, was significant. At the 2-year endpoint, it was 42 versus 68%, which was a remarkable increase of 20%. The overall survival was also improved by 20% as compared to CTRT. Adding nivolumab improved both bladder cancer specific survival as well as overall survival. Coming to the relapses, the survival or the DFS is majorly by the systemic controls. If you see the relapses, there is a difference of around 53 versus 31% in the relapse, whereas the distant relapses is the one which is making the difference. The local regional relapses are 25 and 28%. The trial was well tolerated. Of course, the toxicities were more. Few of them were immune-related adverse events, and of course, there was a 6% increase in grade 3 toxicity. The authors concluded that adding nivolumab to trimodality therapy is significantly increasing bladder cancer specific survival and overall survival, and it was well tolerated. The second trial had a slightly different protocol where no neoadjuvant immunotherapy was given. The pembrolizumab was started along with CTRT, and again a 6 months of pembrolizumab was given, and radiation was cisplatin based. It was a single arm trial. The primary endpoint was feasibility to see for toxicity, and then the secondary endpoints were the disease specific survivals. It was again a T2 T4 trial, but majority T2. Extravesical upper urinary tracts, bulky T3 T4 were excluded. Hydronephrosis was excluded. The baseline characteristics, it was a very small trial, only 28 patients. Median age was 72 years. The pure urothelial cancer was 90%, and again 90% was T2 bladder cancer. All 28 patients could complete the delivery. The relative dose intensity was very good of cisplatin 92% and pembrolizumab 97%. The primary endpoint was not met. The primary endpoint was actually that 30% of the patients, less than 30% shall suffer from adverse event. Here 32% patients suffered from the adverse event. Coming to the tolerability profile, 6 patients had grade 3 non-urinary adverse events, and the adverse events were majorly immune related, such as colitis, polymyalgias, and nephritis. But on a long-term follow-up, after the initial presentation at 31 months, at 5 years, no new adverse events were there. Coming to the disease-specific survivals, the CR rate was 88%, the loco-regional control was 88%, the distant metastasis-free survival was 68% at 4 months, at 4 years, and OS was also 64%. So the median OS has not yet reached till the last publication in 2025 of ASCO. So it was a phase 2 trial proving that combining pembrolizumab with CTRT is safe, feasible, and is yielding high 4 years OS and metastasis-free survival. Though it is a very small gap, it doesn't establish any standard of care, but definitely the trial has opened and there is a randomized phase 3 trial going on. Talking about the same space, there are 3 other phase 3 trials. The 2 trials which have been discussed today have been phase 2. Atezolizumab based CTRT and pembrolizumab based CTRT, as well as considering CTRT along with immunotherapy as well as giving immunotherapy pre and prior. These are the phase 3 trials which are being conducted in the era of bladder preservation, and maybe the bladder preservation may go the head and neck way, and we may change the practice of bladder preservation with immunotherapies giving for 6 months. Thank you.
So we'll move on.
Yes,
to
sure.
the next thing. The thing is, we'll take a quick break right now from the talks. We were not able to do the quiz in the morning for want of quiz master and want of residents also. So we now have some residents and the quiz master both available. So we'll just take a short break right now. Everybody can continue remaining seated in the hall, and we'll have the quiz for the residents. And then after a short 20-25 minute quiz, we'll again continue with the talks.
Um, Thank you to the organizers for this opportunity. So we'll start off with the round one, which is crossword as such for the genitourinary quiz. I would request the participants to sort of come front. All the quiz participants to just come front, please. Yeah. You can sit front. There is no way that both of us are coming for any of your vivas. So don't worry about that. So just come front and we'll start off quickly. All right. So don't get overwhelmed by the crossword. It's just to give you a clue as such. So you can just sit and start filling it. Give a little space, even though there are less contestants. No need to sit. There is enough space to sit. Just 2 per table, please. You can just move out. Yeah. All right. So the crossword has 12 questions. It's going to cover RCC. It is going to cover prostate and urothelial cancers. So we have just used AI to make the slides, not the questions. That's a good disclaimer. So in RCC, the 2 questions that you have is which immunotherapy was evaluated in the Calypso trial for papillary-driven RCC? Which immunotherapy was evaluated? And then you look at, I think it's 11 down, you look at the Renault-Torch trial. Can I have one sheet, Umang? Can I have one sheet? Those in the audience also, please feel free to take part. We'll see whether you're able to beat the residents. Akhil has promised to give a separate prize, including to himself if he wins it. All right. So 3 across is immunotherapy in papillary-driven MET RCC in Calypso trial. What is that immunotherapy? And when we look at the other RCC question, it is 7 across, which is immunotherapy which was evaluated in the Renault-Torch trial alongside axitinib. The beauty of crossword is you can just count the letters and see if it fits along with the starting and the ending. All right, so trial which evaluated belzutifan versus, you can take one more sheet of paper. You can take one more sheet of paper, whatever, yeah. All right, the trial which evaluated belzutifan versus everolimus in clear cell RCC. Now remember, if the trials have some numbers in them, you can ignore it. Any question has some numbers as part of the answer, in the sense you have keynote 568, ignore the 568 part. All right, and then the Napster evaluated addition of what to pembrolizumab as neoadjuvant therapy in localized RCC. This is an acronym. As you can see, 6 down is 4 letters, so it's an acronym. All right, the questions in bladder cancer is the MRI scoring system used to standardize the staging of bladder cancer by evaluating the likelihood of muscle invasion. So that's 2 down. And what is the HbA1c cutoff for exclusion from trials of enfortumab? What is the HbA1c cutoff? All right. Number of months post cystectomy for which testing of ctDNA was carried out in IM Vigor 11. That is 7. That is 10 across. And what was the percentage of CR in patients who received nadofaragine in high-risk BCG. Residents, you really don't need to see the screen. You can just focus on the paper. And lastly, in prostate cancer, very easy question, perhaps the easiest. Which was the biomarker used for inclusion in the Capital 0281 trial? It is H down and a 4-letter word. So very easy to guess. And again, 9 down is which of these is a PSMA radioligand alpha emitter? All right, and Arasafe tested a 2-weekly versus 3-weekly schedule of which drug? And what was added to enzalutamide in MCRPC with bone mets, which improved the PFS in the PEACE-3 trial? So that's 12 questions. You have about roughly 5 minutes more to complete your crossword. Right, 2 minutes left. Just make sure you write your name and college name. Start out with a couple from no speaking between participants. Keep it correct. No speaking. We are standing right here. All right, time up. Hand over your sheets. Please write your name. If you're not writing your name, we will not be able to judge you. Name. Hand over. And done. All right, so time for the answers. So immunotherapy in papillary-driven MET RCC in Calypso trial. Anyone from the audience? Okay, so it is indeed durvalumab. HbA1c cutoff for exclusion from trials of enfortumab. 8 is correct. Immunotherapy evaluated in Renotorch trial along with axitinib. Renault-Torch trial, toripalimab. Number of any torch you go with toripalimab. Number of months post cystectomy for which testing of ctDNA was carried out. It was 9. You know, it's very easy. You just see how many 4-letter numbers are there and take a call based on what else comes. Approximate percentage of complete responders, 50 percentage had complete response with NAT4 gene. Addition of dash to enzalutamide in Peace 3 trial. Radium is correct. MRI scoring system. Virat's. Arasafe trial is for 2 weekly versus 3 weekly. Very simple. It was docetaxel. Belzutifan versus everolimus. Light spark. Napster evaluated addition of. This was SBRT. I said it's an acronym, it's a 4-letter word, so it was SBRT. Biomarker used for inclusion in capital O. That's the easiest question. P10 and PSMA radioligand alpha emitter was actinium. All right. So now how this is going to work is we will count, we will classify you as 1 to 5. And then in the Kahoot, whoever comes 1 to 5, for first place there is 25 points, second place 18, third 15. And then the sum of both the rounds will determine who the winners are. So I think we can put the Kahoot questions, which will be done by Dr. Kunal. Everyone please open Kahoot, and if you would sort of just keep 2 seats, one of you can come in the front row. We had one more candidate here. What happened? Yeah. You can either download the Kahoot app or you can just go to kahoot.it. You can play it online as well. And even the audience can join in, don't worry. There's one candidate here who's... Ma'am, if one of you could come in the front. Yeah. Audience also please join in. You can play non-comp. Like I said, Dr. Akhil has promised a special prize to those who win it. We will tell that. Can we have the slides, please? All right, so the rules of Kahoot is very simple. Download the app and then you enter the game pin, which we will tell you. Please enter your first name. We need to verify it with your Aadhaar card if you need to be eligible for the prize. I'm always fond of telling the story. So in Bangalore, when I do the quiz, someone had put the team name as RCB, did fantastically well for the first half of the questions, and then just crashed down. So... but I don't think I can use that joke anymore. Last 18 years, 16 years, you could do that joke. All right, so remember one thing in Kahoot, it's not just important to be accurate, it's very important to be fast as well, because the faster you answer, the more points. It has happened sometimes that the teams which have answered more have got lesser points than the teams who have answered faster. Yeah, so that's a very important disclaimer. Quizmasters are not responsible for your internet connection or lack of it. Okay, so the game pin that you have is 4991535. 4991535. 4991535.
We also want the audience to join, so it makes the round more interesting. Have all the participants joined?
Can you see your names on the screen that you have joined? What's your name? Venkatesh is there. Your name? You're put as VP. All right, okay. Manoj is there. Ashwin J is written. I think that's a typo. Right, all right. We had one participant here. He went missing after the crossword. I don't think the crossword was so terrifying that he ran away. Right. Organizers, I'm not sure. Are you able to trace that participant? No? All right. So he is declared officially missing. All right. Absconded. Dama. All right. I think we should start. We should not wait. All right. So let's see who the winners are. Over to Dr. Kunal to start.
So I think the first round was quite difficult. Oh.
There's a second round.
So are you on the Kahoot platform? We'll wait for you. Please quickly, we can have the game pin again.
499-1535.
So the pin for the Kahoot game is 499-1535. Okay, so we start with the first question. Remember, you have to be accurate and also be fast. In the NRG's GU005 trial, comparing SBRT to hypofractionated IMRT for localized intermediate risk prostate cancer, which QOL domain showed significant improvement with SBRT? Whether it's urinary domain, sexual function, bowel domain, or none of this. Which domain showed improvement with SBRT compared to hypofractionated IMRT? Few seconds remaining.
Eight of you have got it correct.
So the correct answer is that the SBRT of a dose of 36 gray resulted in better bowel functions compared to the IMRT.
So Anand is in the lead, followed by Prashant, followed by VP. This is the first question. Lot to play for. All right.
We move to the next question. What is the rate of pathological complete response observed in perioperative EV plus Pembro in muscle invasive bladder cancer who are cisplatin ineligible according to EV303 study? Options are 57%, 35%, 21% or 9%. So enfortumab vedotin plus pembrolizumab in perioperative space in muscle invasive bladder cancer.
Okay. 6 of you got it correct. This was something we expected more to get right.
So the PET-CR rates were 57% in the EV plus Pembro versus 8%. We move to the next question. It has just started. So which of the following best explains the differing results between ENZARED trial and the STAMPEDE trial? These are the two trials studying addition of enzalutamide and abiraterone respectively in localized high-risk prostate cancers. So the options are: STAMPEDE included only metastatic patients, differences in case mix and tumor biology, ENZARED used chemotherapy, and Stampede did not include radiotherapy. Which of the following is true or best explains?
7 got it right.
So the correct answer is it is because of the trial mix. We know that Stampede had a higher risk of patients, leading to higher event rate, and Enzared had a lower risk patients. It doesn't mean that the two ARPIs have differing efficacy. So question number 4, and this is a full toss. Disitamab vedotin acts against which target? It's an antibody drug conjugate, not available in India so far, but it acts against which target?
Heavy discussions at Dr. Akhil's table. He's seeing whether the next trial can be run there.
Okay.
Right, only 5 of them got it right. Remember, sometimes even a full toss can go for get bold.
So the correct answer is it targets the HER2, and it is increasingly being used. It was first discovered for use in gastric cancer in China, and now increasingly being used in HER2 positive bladder cancers like micropapillary. We move to the next question. Question number 5. Back to your basics. A patient with multiple bilateral renal tumors and pneumothorax is most likely to have which hereditary cancer syndrome? Whether it is VHL, HLRCC, tuberous sclerosis, or Birt-Hogg-Dubé syndrome. Bilateral renal tumors and pneumothorax.
Six of them got it right.
Okay, so the correct answer is BHDS, caused by alterations in the folliculin gene, characterized by skin anomalies, lung cyst causing spontaneous pneumothorax, and multiple bilateral tumors. Most commonly they are chromophobe or oncocytic. Okay.
Right, moving on to the next question.
Regarding the Keynote 564, your favorite trial for adjuvant pembrolizumab in resected RCC, which of the following statements is true? They are longer statements, so you.
This question
please read
comes down to
carefully.
who can read fast.
You need to mark the true statement for Keynote 564. Time is up.
10 of them got it right. A majority, only 1% got it wrong.
And we know that it has shown benefit in both OS as well as DFS, and we have a very significant benefit. We move to the next question.
Okay, so this is the halfway stage. So quick update on the leaderboard. Dr. Prashant is leading with 5291 points. Akhil seems to be very happy about it for some reason. Followed by Vivek, who's one of the contestants, leading at 5243 points. Very, very close. Followed by ANK. Who is ANK? All right, with 4262 points. And AK and Manoj. Very, very tough and tight, but can they actually end up beating the residents towards the end? That's what we are going to see. All right, moving towards the second phase of the quiz.
And the questions might get a lot easier now. Which of the following was the most common side effect in PSMA addition trial with lutetium PSMA therapy? Most common side effect of lutetium PSMA in PSMA addition trial. Whether it was hematological or neuropathy or dry mouth. These are your options. Time is up.
7 got it right. Disappointment there in one table. Sometimes the ball can swing like Bumrah's swing.
So dry mouth was the most common side effect, as we know, 41%. Grade 3 side effects only 14%. Right? We move to the next question. Again, which of the following best describes the primary outcome of the PRIME trial? PRIME trial compared biparametric MRI versus multiparametric MRI. So again, who can read the sentences faster? You have to select the true statement.
All right, again, only 7. I think 7 is the number and the flavor of the day. Tala for a reason, as they say.
So PRIME trial was a non-inferiority trial, and it showed that biparametric and multiparametric are kind of non-inferior to each other, and it can be used for Gleason's grade above 2. Okay, so we move to the next question. What is the half-life of AFP in the serum? This is like a batsman bowling a yorker, and it's getting,
Wow.
and I'm getting it wrong.
No one needed 30 seconds, done in 3 seconds with even one of the audience members prompting. No changes in the leaderboard with this question. The easiest question where everyone hit it for a 6.
Okay. Next question, another potential no ball and 6. What is the standard dosing schedule of relugolix in prostate cancer?
All right, 9 of them got it right. 2 actually got it wrong. Like I said, sometimes a no ball can also get you run out as such. But then at the end of 10 questions, in the lead is Vivek with 8797 points, followed by Prashant with 7971 points. Vivek has the highest answer streak of 10 questions being right. Really remarkable. Manoj at 6684 and Dr. AK at 6148. Very tight. Last 5 questions, log overs. You can lose wickets in a hurry or you can hit it for a 6. Will the 6 travel all the way to Varanasi is what Dr. Akhil is looking for right now. All right, moving to question number 11.
Which of the following statements is true regarding SPOP mutation in prostate cancer? And Dr. Akhil is very happy reading this. Which of the following is true regarding SPOP mutations in prostate cancers?
Only 5 got it right. That was a vicious in-swinger from Dr. Kunal, prepared at 1 a.m. in the night.
So SPOP mutation is heavily dependent on androgen receptor signaling, and it is based on proteasomal degradation of androgen receptor pathway. So these cancers are highly sensitive to hormonal agents. We move to the next question. Which of the following genes is not directly involved in homologous recombination repair set of genes? So 3 of them are HRR genes and 1 of them is not. So you have to identify which one is not. Sorry, I don't have BRCA in this. Okay.
Oh, only 1 got it right. Oos and ahs all around the ground.
So it's check 2. Check 2 is linked in DNA damage repair, but it is not considered a HRR gene.
Who was the one who got it right? Yeah, please give a big round of applause. The only person to get it right.
So now 3. What is the physical half-life of lutetium-177? So this is kind of a breather for all of you after 2 tough questions. Half-life of lutetium-177.
There's some heavy match fixing happening at one table. We need a DRS on that. This is not going to be alone.
I expect all of them to be right. Oh.
6 of them got it right. I think there's only one nuclear medicine person in the hall and he's sitting at the table. Right.
So it is 6.7 days. Okay. Last 2 questions. Come on. What is the primary mechanism of action of mirabegron in the management of overactive bladder? And I can see all the surgeons smiling and having their best time of their life. Finally, after a lot of mutations, this question has come. We keep on prescribing it every day in and day out, but let's see the mechanism.
All right. 8 of them got it right.
So it is a beta 3 agonist, relaxes the detrusor muscles and increases bladder capacity. Remember the important side effect of hypertension.
Right. So last question coming up. This question carries the same points. Could be an easy question. It could be a tough question. But the most important question of the quiz, because it's still very, very close between the top 3. But of course, between the residents, we will tabulate once the quiz is over.
Okay. So last one. Which of the following is the most characteristic adverse effect with belzutifan?
If you know the mechanism of action, it would be very easy to guess it. Thankfully,
The voices from Varanasi have
have
reached
been
all
very
up to Mumbai.
overpowering as on the national scene. But anemia is the most common answer.
So hypoxia and anemia because of inhibition of HIF2 alpha. And now let's have the
All right, so this is for the Kahoot round. This is not for the overall quiz. The overall quiz, like I said, is going to be a combination of Kahoot with the crossword which has happened. So coming in third place in Kahoot with 910 points is Dr. Manoj. If Dr. Manoj, you can stand up. Don't feel shy. Right, in second place is Dr. Vivek, the one who went missing. He took a break, came back and has rocked the Kahoot quiz. And in first place, though we need to subtract at least 1,000 points, is Dr. Prashant from the Varanasi table out there. Big round of applause. All right, we really hope you had fun in attending this quiz and you had learnings and a good revision as such. We will shortly announce the winners once we check the crossword scores and tabulate them as well.
You will need some time to do that. So then we'll move ahead with the session. So we can go ahead with the session, right? So we'll have our chairpersons back on stage. And we'll go on to the next talk. And the next talk is by Dr. Vivek.
Good morning, everyone. Today I'm going to talk about peri-op pembro with AV in cisplatin ineligible patients. This has been published in NEGM in February 2026. Background for the study is neoadjuvant cisplatin-based therapy with or without IO being the standard of care in muscle-invasive bladder cancer. However, half of the patients are ineligible for the cisplatin, and they directly proceed with the standard of care with surgery and with or without IO. And the cisplatin ineligibility as per Glalsky criteria, renal impairment, creatinine greater than less than 60, ECOG performance score of more than or 2, NIHA heart failure more than class 3, grade 2 or more peripheral neuropathy and altered hearing loss. Patients usually are elderly with multiple comorbidities and have poorer outcomes. And the median reported event-free survival in these patients are around 12 months. And the study itself is a Keynote 905 EV303. The key eligibility criteria is up to T1 to T4 and N0, N1 patients with more than 50% of urological histology, and cisplatin eligible patients or patients who are declining cisplatin with the ECOG performance score of 0 to 2. And initially the trial had 3 arms, but the first arm, the pembro arm, they removed from November 2022. So the rest of the 2 arms, which is directly surgery, then observation, but after 2022, the observation arm, 18% of patients received adjuvant Nivo, and the experimental arm is EV with pembro, 3 cycles pre-op, then up to 1 year of EV, up to 1 year of pembro. And the key endpoints is EFS, OS and PathCR rates, and pathological downstaging, and DFS. The demographic, out of 344 patients, 170 patients been allotted to EV with Pembro and 174 patients in control arm. In EV arm, almost 92.6% of patients underwent surgery with negative margins, and only 78% of patients underwent surgery in control arm. And we can see here is almost 12% of patients are in PS2, and 80% of patients are, more than 80% of patients are cisplatin ineligible. And if you see, it's more than 80% of patients are stage 3 patients. So this is what 80% of patients are cisplatin ineligible, and 80% of patients are stage 3 with T3 or N0 or T4 N0 or node positive patients. And the pathological CR rate, pathological CRs are almost 57% in EV Pembro arm compared to 8.6% in control. And the CRs are seen in across all the groups. And the pathological downstaging, which is defined as less than T2N0, it's been seen in almost like 66% of patients compared to only 12% of patients in control arm, with estimated difference of 53%. If we go cross trial, we should not do, but the most of the trial they took cisplatin eligible patients. This is the only stage 3 trial which took cisplatin eligible patients and node positive patients, and with the poor PS patients. Even though this trial showed a good pathological CR rates of almost 65%, which is the highest among all the NACT trials. And the DFS is almost 83% versus 49% at 24 months, with a median DFS not been achieved in EV Pembro arm versus 23 months in control arm. And DFS benefits have been shown across all the patient groups. So the conclusions are the pathological outcomes and DFS are favored neoadjuvant and adjuvant EV Pembro compared to standard of treatment, with the negative surgical margins of almost 92% versus 78%, and PathCR rates of 57% versus 8.6, and the pathological downstaging of 67% versus 12, and median DFS not been reached versus 23 months. The SWOT analysis of this trial, the strength is this is a phase 3 trial with all 3 endpoints being met, and this addresses the most important group, which is cisplatin ineligible group, and it showed a consistent benefit across all the subgroups. The weakness being it's open labeled with more than grade 3 adverse effects of 71%, and 37% of patients discontinued the drug after surgery. The neoadjuvant versus adjuvant, the roles are still not clear. The PathCR has not been validated as a surrogate in MIBC as of now, and the disclosure of PathCR in this patient may bias the adjuvant decisions. Opportunity enables the bladder preservation in poor candidate, extends the curative intent beyond the surgery. Chemotherapy-free neoadjuvant regimes extending to even to cisplatin eligible patients. And the third is long-term safety with RT in this patient. We don't know real-world tolerability in frail elderly patients. We don't know stratification outcomes. They didn't show that outcomes, and there is no head-to-head comparison with the cisplatin eligible patients. And the control arm, like I said, they received almost 18.6% of patients received adjuvant nivolumab, which may dilute the benefit of this trial. Thank you.
So next we would call Dr. Srivatsan R, who will speak on long-term results of LEA trial for lymph node dissection.
Thank you and good morning. This is a very important trial comparing the nodal dissection. It's always been a controversy in both, it's especially in prostate, but recently in bladder as well. So this is the LEA trial, AO AB25R2. The context is muscle invasive and high-risk bladder cancer. The clinical question was the extent of the lymph node dissection, extended versus standard. The rationale, whether it is therapeutic versus staging benefited lymph node dissection. So it's a proper randomized multicentric trial of 16 centers, 401 patients, 1:1 randomization, standard versus extended lymph node dissection. The most important caveat being there was no neoadjuvant chemotherapy. The primary endpoint was recurrence-free survival, and the secondary endpoint was CSS and OS. The patient characteristics were properly matched. It was T1, G3 and T2, T4 urothelial cancer, M0 disease, multi-center German cohort, high surgical expertise center of more than at least 30 RC per surgeon or 15 RC per site per year. So we all know the standard was as extended. Extended is various denomination, but mostly it is the common iliac pre-sacral nodes. So these are the representation of the limited versus the standard versus the extended lymph node dissection. I'm not going to go into the details of that. So coming to the results, it was found that when it comes to the primary endpoint, which is the RFS and the OS, there was not much significant statistical value, whereas when it came to the cancer-specific survival, it was found to be significant. Let me go into the details of it. So the endpoint was actually, this is the primary endpoint, which was the 5-year RFS, and RFS thing was not achieved by this trial. So whether you do a standard or extended, it was the same. And same with the overall survival as well. So these two endpoints was not achieved by the trial. However, when they calculated the cancer-specific survival, it was found to be statistically significant with a hazard ratio of 0.65. So interpretation is that the primary endpoint was not met, signal towards improved CSS, possible micrometastatic clearance. However, it was underpowered for RFS. There is only one more trial similar to this, which is the SWOG. Now, this is the direct comparison of this. So if you compare the SWOG versus LIA, it is almost that the important factor was that 57% received the neoadjuvant chemotherapy, which is generally assumed to be the standard of care. So this was not in this trial, whereas the result was all negative for both the trials. So, but only this trial reported the CSS value. So let's go into the details of the trial, just a couple of more slides and end with that. The strength of the trial is, it was a very rigorously designed trial, 1:1, 16 German, all high experience centers and so forth. And there was a clean comparison. There is no factor which can change the question because there was no chemotherapy. So it was standardized across the this thing. Allows assessment of the true impact of LND, whether the chemotherapy has changed the outcome or not. Meaningful node yield, yes, definitely it was an experienced surgeon. There was a good amount of node yield, whether you have done a standard versus extended, and the follow-up was quite long as well, 58.4 months. However, it is an underpowered trial, and this is the most significant flaw of this. There was also a heterogeneous patient population, which included starting from grade 3 T1 to T4, so it's kind of variable as well, including the biology. Outdated treatment context, because neoadjuvant is a standard of care, this was not included in this. So how do we actually relate it in this era is something we do not know. The secondary endpoint. So while calculating the CSS finding, though it is intriguing, it must be interpreted cautiously because it was neither the primary endpoint nor was it like increased false positive risk while highlighting the favorable secondary results. So it could be like deriving, sidewards that did the same. And there was a single country problem. It was only a German trial, a Caucasian trial, which we do not know whether it will be effective in our setting as well. Verdict? We can conclude to a certain extent that extended does not provide a large definitive surgical benefit. Standard remains the minimum acceptable template. That has to be the word. It's not that you avoid lymph node dissection, but a minimum standard should be achieved. CSS is hypothesis generating, but not practice changing on its own. What remains uncertain is that a modest benefit exists, that both trials were underpowered, and however, LND extent interacts with the modern perioperative chemo. How it's going to change, we do not know. Whether specific subgroups, including the nodal negativity as well as high-risk victors, might benefit more with a lymph node dissection. So overall quality assessment is this. It is fairly okay, but not the greatest. Coming to the good bad, one of the only two trials comparing these two, it is honest about its limitations. The bad, it is too small to actually arrive at a conclusion whether we should do it or not. The clinical bottom line is that in the era of perioperative systemic therapy, whether this is going to be a benefit to us or not. So coming to the question it raises, should we have a new trial comparing in the IO era? That would be the more this thing, and CSS is not the way to go forward. Thank you.
Any questions from the audience? So next speaker is Dr. Nikhil Kalyani from Jaslok Hospital, Mumbai. He will be speaking on the long-term results of Cysto trial.
Good morning, everyone. I will be presenting a results of a 12-month cysto study comparing the radical cystectomy versus the bladder sparing therapy for recurrent high-grade non-muscle invasive bladder cancer. Bladder cancer is a relatively uncommon cancer. Non-invasive, non-muscle invasive bladder cancers are the commonest. However, with a TURBT plus the intravesical therapy, there are high recurrence rates, which ranges from 25 to 60%. For a recurrent high-grade non-muscle invasive bladder cancers, the bladder sparing therapies like three intravesical therapies versus cystectomies remains the option of treatment. Patient preference for the further treatment is important, and cystectomy is considered as a morbid surgery. So in present study, they aim to compare the patient-reported quality of life outcomes and the clinical outcomes between the bladder-sparing treatments and the radical cystectomy. This is a prospective cohort observational study. The primary endpoint was a difference in the patient-reported physical functioning at 1 year on the URTC QLQ30 questionnaire. And the secondary endpoints were the other functional quality of life domain and the clinical outcomes like recurrence-free survival, PFS and OS. So for the inclusion criteria, they included the patients with a recurrent high-grade non-muscle invasive bladder cancer, TIS, TA or T1. All the patients must have received the previous intravesical BCG within the 1 year of the enrollment. Patients should be eligible for both bladder sparing therapy and the radical cystectomy. Exclusions were medically ineligible for any of the arm and previous history of a muscle invasive bladder cancer. The treatment was decided as per the patient's choice and the consent was taken after the treatment decision made by the patient. So this is the concept diagram. They screened 986 patients and enrolled around 590 patients. So between July 2019 to December 23, they enrolled 570 patients, 371 patients in the bladder sparing therapy and 199 patients for the radical cystectomy arm. The mean age was 71 years and almost 90% of the patients completed the filling of the QIL forms. Coming to the results, in the bladder sparing treatment group, additional BCG was given in 109 patients. Intravesical combination of gemcitabine and the docetaxel was given in 200 patients. Intravenous pembrolizumab was given in 27 patients and no additional treatment was done in 17 patients. In the radical cystectomy group, mean time to surgery was 2.8 months. Robotic surgery was done in around 50% of the patients and the ileal conduit was done for around 79% of the patients. In the pathologic staging at the radical cystectomy patients, almost 23% had a T2 to T4 muscle invasive tumors. So upstaging was there. Coming to the primary endpoint, there was no difference in the physical functioning at the 1 year between the two arms. The radical cystectomy arm had a better emotional function, cognitive function, global health, anxiety, depression, and the urinary function scores. Radical cystectomy arm had a worse bowel and the sexual function. There was no difference between the two arms in the role function and the social function. And the bladder sparing arm had a higher financial toxicity because they needed multiple cystectomies and multiple cystoscopies and the further treatments. So these are the time-dependent quality of life scores between the two arms. The upper one shows the RC is better, the below one was the BST was better. In the bladder sparing arm, around 8% of the patient underwent radical cystectomy because of the recurrent tumors. The recurrent-free survival was better in the RC arm, the PFS was better in the BST arm. There was no difference in the metastasis rates and the overall survival between the two groups. Serious adverse events and the IPD admissions were higher in the radical cystectomy group. These are the clinical outcomes between the two. The limitations of the present study is it's the observational trial, not a randomized trial.
The authors have concluded the patient preference is important, so it was very difficult to obtain the consent for the randomized trial, so they devised this cohort study. There is a heterogeneity in the treatment arm for the bladder sparing therapy, and it's a short-term follow-up, only 1 year of follow-up. So conclusion, for the recurrent high-grade T1 bladder cancer, radical cystectomy, though morbid, remains a viable option. It has a similar physical function, less anxiety, less financial burden as compared to the bladder sparing therapies. Bladder sparing therapies have a better bowel and sexual function, comparable oncological outcome between the two groups, and personal preference should decide the choice of treatment for the patients. Thank you.
So next we'll call Dr. Vinay Babu, who will be presenting bladder only versus whole pelvic RT and TMT treatment for lymph node negative urothelial muscle invasive bladder cancer, systematic review and meta-analysis.
Good morning, everyone. I would like to thank the organizers for giving me this opportunity. Today I will be discussing paper on bladder only versus whole pelvis radiotherapy in trimodality treatment for lymph node negative muscle invasive bladder cancer. It's a systematic review and meta-analysis by Dr. Granda and her colleagues from Manila, Philippines. This is presented in abstract form. The full paper is not available yet. Coming to introduction, we know that MIBC accounts for 25% of the bladder cancers, and TMT is the standard of care for select group of patients, which involves maximum TURBT with concurrent chemoradiation. And the optimal radiotherapy volume for this muscle invasive bladder cancer remains unclear, and especially if this elective pelvic lymph node irradiation in lymph node negative disease adds any benefit. This study aimed to compare efficacy and toxicity of bladder only radiotherapy versus whole pelvic radiotherapy in lymph node negative muscle invasive bladder cancer. The hypothesis is up to 25% of these lymph node negative patients may harbor occult nodal metastasis, including pelvic lymph nodes in the RT field can improve oncological outcome by addressing potential micrometastasis. Coming to methodology, Dr. Granda and her colleagues conducted systematic review and meta-analysis of randomized control studies, prospective and retrospective studies published from 2012 to 2024 using databases like PubMed, Google Scholar and Science Direct. The primary objective of the study was to evaluate overall survival, DFS and cancer-specific survival and toxicity outcomes. Over 1,000 articles were identified, and after screening, 6 studies were included, which included more than 3,600 patients. Among these 6 studies, 3 were randomized controlled trials and 3 were retrospective studies. To assess the risk of bias, authors used Cochrane ROB2 tool for RCT trials and Cochrane Robbins tool for non-randomized control studies. To assess the risk, they used these tools which help the authors to decide whether these these studies were trustworthy, and you can appreciate here the overall risk of bias was low to moderate in both randomized and non-randomized studies. Coming to results, this forest plot compared overall survival between whole pelvic RT versus bladder only RT. And you can see here the odds ratio is 0.6, that is nearly 0.76, nearly 24% reduction in the mortality with whole pelvic RT. And forest plot comparing a cancer specific survival, again the odds ratio is 0.7, nearly 30% reduction in the cancer related mortality with pelvic RT. However, there was no difference in disease free survival between whole pelvic RT and bladder alone RT. Coming to toxicities, acute GI toxicity favored bladder alone RT. However, there was no difference in the late GI toxicity. Similarly, there was no significant difference between acute or late GU toxicities. So authors proposed treatment selection framework for these patients, and they favored whole pelvic RT if priority is on overall survival. Say for these patients like high risk features, younger and fit patients with acceptable GI toxicity, and they considered bladder alone RT if priority is quality of life, like elderly patients, significant comorbidities, and with previous pelvic and pelvic surgeries or previous radiation to the pelvis. So to conclude, whole pelvic RT provides significant survival benefit over bladder alone RT in lymph node negative MIBC, and the survival advantage of whole pelvic RT should be balanced against the trend towards increased acute GI toxicity. The future research should focus on identifying patient subgroup most likely to benefit from each approach through molecular markers and advanced imaging techniques. Thank you.
Any questions from the audience?
No, sir, I didn't get you. Correct.
So the trial, the thing is, may have used 3D CRT or, the thing is obsolete techniques. So the emphasis should be that, use
I
more advanced.
agree with the most advanced radiation techniques probably would make sense. Probably it will reduce the GI toxicity.
Dr. Vinay,
Because there is a BART trial as well, even, for bladder, the thing is, they're using.
They've used IMRT mainly.
They've used IMRT.
Correct.
And, the toxicity is minimal, grade 3.
Acceptable
2%,
toxicity.
3%.
GU grade 2 toxicities were around 20%, grade 3 was less than 5%. Exactly. Less than 5%.
That's acceptable.
Correct, agree.
Dr. Vinay, only one question. Why there was no difference in PFS? Why what was not significant?
There was no difference in
Why the difference in PFS was not significant with pelvic cardio, addition of pelvic cardio?
DFS.
Why it was not significant? We had a better survival.
Full paper is not available, so there was no discussion. This was just abstract form.
It's a very pertinent question.
Agreed. But this is only presented in abstract
Because
form.
if you see the POP RT trial, we had a difference in DFS, not in OS, in prostate. This is like.
Agreed.
Any comments from the audience? Vedant sir is there.
See, I don't know, the picture is not here. So basically, they studied between two groups. One is only bladder alone, that is entire bladder plus 1.5 centimeter margin around the bladder. In other group, they used the bladder with margin plus the pelvic lymph nodes from common iliac to obturator nodes. So whether this involvement of pelvic node group has shown any benefit or not, that was the.
Vinay, it is important to know what the techniques was used in these studies, because if you are using a 3D CRT, you will end up treating, even in a bladder only RT, you will end up treating a part of your nodes. Okay. So in spite of that, I don't know what.
No, obturator nodes will be included if you are using
Right.
bladder
I don't
only.
know what these studies used, but in spite of that, there is a difference in the control rate or whatever the endpoints. We don't know.
Don't know.
Dose is 50.4, right?
Dose 50.4.
Mentioned in the paper, right? 50.4.
So I haven't gone through.
No, if margin positive, they've gone higher, 60 to 66. If margin negative, it's 50.4.
I think it's asking the pelvis dose, nodal dose. Not the primary.
And I'm sorry, I haven't read the entire paper, but
No, entire paper is not available.
I know. So based on whatever is there, it kind of seems very counterintuitive. I'm a surgeon. There'll never be a trial, a surgical trial, where you say I'll remove only the bladder and not do the nodes, compared to doing the do the nodes or not. That's number one. Second, there also is really no data, or to the best of my knowledge, that tells you that in a T2 disease or a T3 disease, you will have, if it's a T2, it will always be node negative. That you don't have to irradiate, that you don't have to remove the nodes, because in a T2 disease, it will invariably be PN0 also. That kind of data also doesn't exist. So this trial to me seems kind of like a hodgepodge trial, where they've done bladder irradiation with pelvis for somebody, and they've done only bladder irradiation, which I think should not even be considered as the standard of care. That would not even be under the purview of curative treatment. We'll end up looking like fools if we do this. We give bladder radiation, and a couple of months down the line, patient has got bilateral pelvic nodal recurrence.
That's what the Europeans they did. What they used 1.5 to 2 centimeter margin around the bladder, and they say that covers more than 80% of the lymph nodes, positive lymph nodes. And in those group of patients, the pelvic failure is less than 10%.
Yeah, but it's still 10%.
Thank you.
So next speaker is, can I call the next speaker, please? So next speaker is Dr. Prachi Mehta from Bhaktivedanta Hospital, Mumbai.
Good morning, everyone. So today we'll be discussing on the role of ctDNA in patients treated with trimodal therapy. This is my disclosure, so thank you, Notebook LLM. These are the original authors of the study, Epstein et al. From Dana-Farber and MGH Hospital. So before we begin, let's understand what is ctDNA. So many tumor cells shed their DNA into circulation, and measurement of this value in plasma is known as ctDNA. The role of ctDNA in post-radical cystectomy is well established. However, in setting of TMT, it is not really explored. In TMT, what we do is we offer patients initially maximal safe resection of tumor, followed by chemoradiation, and then they are surveyed with routine cystoscopy, urine cytology, and 3 to 6 monthly imaging like CT, thorax, abdomen, and pelvis. And during this surveillance, whoever has a local recurrence, they are offered salvage cystectomy. And in the setting of metastatic diseases, they are offered palliative chemotherapy. Therefore, to pick up such cases, be it even local recurrence or a distant metastasis, is of paramount significance so as to offer treatment. So in this study, all the eligible patients underwent serial plasma ctDNA analysis. So the endpoints were initially at the diagnosis, that is post-URBT. Second analysis was done post-chemoradiation, that is 10 to 12 weeks post-chemoradiation. And then subsequently 3 to 6 monthly along with the routine surveillance program as advised. So during surveillance, patients who had a ctDNA positive were deemed high risk, and patients without any ctDNA were deemed low risk. So this is a demographic profile of the patients. 84 patients were found to have at least one plasma value of ctDNA along the various time points. Median age of the cohort was 75 years with predominant male preponderance. And most of the cases had early stage. Few were node positive, and about 20% were T3, T4. Almost more than 90% received the intended radiation dose, and also non-urothelial histology were quite a few, about 14%, and about 20% also received NACT. So at baseline, that is pre-chemo radiation, ctDNA status was available for 59 patients. And out of these 59 patients, almost 1/3 had their ctDNA value positive. And it was seen that patients with locally advanced cancers were more significantly associated to have a positive ctDNA at baseline. This water flow diagram shows analysis in 46 patients with pre and post chemo radiation. So again, out of the 59, again 1/3 patient, that is 15 patients had their ctDNA positive, and most of them, that is 11 out of 15 patients, were deemed negative post chemo radiation. and only 4 had persistent ctDNA post chemoradiation. So if we see the patients who did not have ctDNA at baseline, they remained ctDNA even after treatment, and only 2 of them were converted to positive, one with positive ctDNA value. At median follow-up of around 11 months, it was found that 16 patients out of the 84 initially evaluable patients, that is 19% had a metastatic disease, 6% had local MIBC failure, and 7 patients had local NMIBC failure. So out of the 16 patients who had experienced metastatic disease, almost half of them, they had ctDNA positive post chemoradiation, and the remaining 5 patients in the cohort who were initially ctDNA negative post treatment were later converted to positive ctDNA during routine surveillance. And in every of these 5 patients who were converted, all the patients were subsequently diagnosed with metastatic disease. And plasma ctDNA conversion preceded the clinical and radiographic evidence of metastasis by a median of 8.3 weeks, thus giving a lead point of around 2 months. So as we can see here, in the separation of the curves itself, that a detectable ctDNA following chemoradiation is strongly correlated with metastatic recurrence. Every single patient with persistently detected ctDNA following trimodal therapy developed clinical evidence of metastatic disease. So as again, I would like to highlight that nearly every patient who had a ctDNA positive eventually developed a metastatic disease, whereas out of those 12 patients who had a local recurrence, ctDNA was not found positive along the timeline. So why possibly this is happening is because local recurrences are picked up on routine cystoscopies and cytologies much sooner before they even shed into circulation. So if we compare the pattern of recurrence, so metastatic recurrence was seen in 19% as opposed to 14% local recurrence, and all the metastatic recurrence patients had their ctDNA positive, and this is because of the systemic vascular shedding. So what the authors are proposing in this study is that we need a dual surveillance framework, that is plasma ctDNA as well as urine ctDNA, so as to pick both local and systemic recurrences. Thank you.
So I've been told we're running a bit behind schedule, so we'll move on to the panel discussion on these abstracts. And I would like to call the moderator, Dr. Anand Raja sir, and you can then call the panelists.
Yeah.
Before the panel started.
Okay. So it was a very tough one. So we had someone who won the quiz, Kahoot, but came last in the cross, 18 to both of them. And then there was a tie again between Dr. Vivek and Dr. Vasant Priya with 15. But overall, looking at both the Kahoot and this thing, the winner is, so he came first in crossword and second in Kahoot. So obviously no brainer. The winner of today's quiz is Dr. Manoj. He fantastically aced Dr. Kunal's tough Kahoot quiz prepared at 1 a.m. But he came sort of last in the crossword, but by a very narrow margin of 1 point. But coming in second place is Dr. Vivek. Please stand up so that people know who you are. Yeah, thank you so much. And coming in third place with actual consistent performance, coming in third both in Kahoot, in the crossword and the overall quiz is Dr. Ashwini. Big round of applause.
Thank you all for participating. We wish to see more numbers
Thank you.
Varanasi table has to give the prizes to others. Organizers just wanted all the winners to come participate. And all the participants, actually everyone come in. Yeah.
So without much further ado, I think we're already running late. I'd like to call upon my panelists for this session, Dr. Darshit Shah, Dr. Srivatsan, Dr. Amandeep Arora, Dr. Vedang, Dr. Vinay Babu, and Dr. Akhil Kapoor. So a few house rules before we start. I am the moderator of the panel. I get to ask all the questions. I encourage all the audience to come up with all their questions, and all the people that will answer the questions are sitting right there. So, you know, the questions may be wrong, but the answers are never wrong. So very quickly coming in, let's quickly go. So, we had a little bit about, so what we'll try to do is we'll try to go along a particular set path. We'll try to look at NMIBC, then we'll try to look at MIBC, and then we'll try to look at, you know, ctDNA and look at advances and how is that we do. So we had the JCOG 1019 trial, which tried to look at whether we could omit BCG therapy in bladder cancer. So Dr. Srivatsan and Dr. Amandeep, since both of you are the surgeons here in the group, what are the single most important eligibility criteria in this trial that is reliably achievable in practice? I am assuming that the presenters of the paper are also around. So if there is some mistakes in my understanding, you could please correct me. Yeah.
So they wanted the re-TURBT specimen to be negative,
yeah,
actually, which is usually what we also have. It is probably just a second check to make sure we are not missing something before we start intravesical therapy. It is a little hard to believe that not doing anything is as good as, you know, we've been giving BCG for so many years.
Absolutely.
And 87% 5-year RFS in the active surveillance arm.
Which is more than the survival in the intervention arm.
Yes, and much, much higher than what we see with BCG in all other studies that have been published till date. Little hard to believe, but the authors themselves say that this is challenging the dogma. So,
I'll come back to you with two other questions here. So in this trial, they showed us that only about 50% of the patient achieved the PT0 disease, and 50% did not, which is not there in our case. In our case, unless you have that extensive disease, you know, which is coating all walls of the bladder, you would get a PT0 disease at the end of TURBT. So the question here is, were they only super selecting a very small subgroup where they did aggressive PT0, where they got everything out, and anything more than that they probably did not resect? So were they super selecting a small subgroup of patients to enroll in the trial?
I think so. I think because they have been selective, they were actually able to achieve this. And in practical points, like whatever we face every day, I don't think this is, again, the results are too heavily telling us that it is workable. So, which is, I'm not very sure.
So
about
probably my take on this is that this P-T0 I think is something that we achieve in majority of our patients. If we have to include this super selective, and all patients were high grade cancers. So if we have to include this as part of our armamentarium in our routine practice, we probably have to quantify either the size of the disease or the number
Load
of
of the
lesions.
disease.
Either 1 or 2 lesions which are high grade, and then you don't do anything for these lesions. I think that would make it a little more impacting in terms of this study translating into clinical practice. Otherwise, I don't think that we would be changing our practice based on this. Your thoughts? Is my interpretation correct?
Correct, sir. It's not changing routine practice. It's just that in somebody who's elderly, already has large, small, single papillary pedunculated T1 high grade, if the patient asks, "Kuch nahi kiya to chalega kya?" there is some data to say that, okay, fine, we may not do anything in you.
Absolutely, absolutely. So again, in this trial, looking into a little bit into the nuances, so they told us that the non-inferiority margin, they took the hazard ratios as 1.6. Do you think that a hazard ratio for non-inferiority at 1.6, we'll come to what was the final hazard ratios in a bit, but the hazard ratio of non-inferiority of 1.6, do you think this was acceptable, not acceptable as a study design, as a trial to start with? Dr. Vedang. So I'm asking you those questions because this is a statistical question. You've done a lot of prospective trials, so your opinion on this.
I don't do the statistics for my trials, so that's the disclaimer. But you see, when trials are designed, certainly our trials, we have to bring in pragmatism rather than idealism. That is a key thing. And if you are using a 1.6 HR non-inferiority margin to set your sample size, because if you put it at 1.2, 1.3, you'll never be able to achieve you'll never be able to recruit that many patients. So I think it's pragmatism. And you hope that it will not reach 1 point. It will be less than that, the margin. So I think this is more about that.
So when I kind of went into the study trial, I kind of looked at this 1.6 hazard ratio. So this 1.6 hazard ratio translates into the survival. What they were effectively telling you is that in the intervention arm, which is active surveillance, a 10% reduction in survival compared to the standard arm of BCG would still be considered, if one was 80 and the other was 70, a 10% reduction in survival would still be considered as
acceptable,
as acceptable or as equivalent survival, which I thought for a disease, even though there are multiple steps to the disease, NMIBC, nobody dies of it today.
Correct.
But a 10% increase in recurrence, I thought was pushing the bar slightly higher. But yeah, you have something.
So it's about pragmatism in our own. So that has to come at some benefit. The benefit has to be there to accept that 10% non-inferiority margin. I think Vanita is here. She can also, she's an expert in this as well. She's done non-inferiority trials and maybe give an idea of what an investigator thinks.
I totally agree with you, Vedang. And 1.6 is pushing the envelope quite a bit. I mean, I don't think our ethics committee would have approved that. That said, I have to appreciate the maturity of the ethics committees of all of these institutions that did the study. Ultimately, as you said, you are trying to balance the risk and the benefit. So, and this is a hazard ratio for relapse. It's not for OS, right? So,
yes, it's a hazard ratio for relapse.
So I'm putting that, I think it is maybe appropriate, and it gives us ideas that what should be considered appropriate. I mean, you cannot run a 5,000 patient trial, right? I mean, that's absurd.
So for example,
I'll ask you to stay there for a minute.
When we have, so our
trial in prostate cancer of 5 weeks versus 5 days, the prime trial SBRT versus 5 weeks, we've kept a 9% non-inferiority margin for biochemical failure. Because we are giving the patients an advantage of finishing the treatment in 1 week instead of 5 or 6 weeks, and that's biochemical failure. That doesn't mean they are not going to...
at a cost. I get it.
So it's pragmatism, and that's still 560 patient sample size.
And how do you explain that instead of going, landing up in that 1.2, 1.3 zone, the trial landed up with the hazard ratio of the exact opposite. The hazard ratios for the active surveillance in favor of active surveillance came out to be 0.69. So does that reinforce what I said in the beginning, that they were probably looking at very small tumors to begin with that they put in the active surveillance arm, and the larger tumors that were resected, that could not be resected completely, and then that gave BCG. Although that they haven't explicitly said that in the paper, could the selection bias of patients have resulted in this extreme hazard ratio in favor of active surveillance in a high-risk NMIBC? Both.
This was an RCT, right?
Yeah.
So unlikely. I mean, usually in an RCT, it is very unusual that you would get such a stark difference in populations in the two arms. By and large, usually you assume that due diligence has been done and then the appropriate randomization has been done. That said,
active surveillance faring better than treatment in a high-grade disease.
So usually in non-inferiority trials, the de-escalation arm tends to be inferior but not very inferior, but it turned out to be superior to the test arm, which is a little difficult to believe. But Tokyo strain, because it was a completely Japanese trial. No other place in the world is a Tokyo strain used. Okay. But it was published in European Urology, which is the highest impact factor urology journal, which means thorough checks have been done about methodology. Okay, that is how it is.
This is the beauty of generating evidence, right? If we already knew the answer, why did we do the study? So if we got an answer that we didn't like, but hey, that is the answer. That is the evidence.
Yes.
So coming to the addition to the so going away from doing nothing to doing extra on top of BCG, coming to the CREST versus the Alban trial. So the CREST trial, which used the sensalimab, and the Potomac trial, which used the durvalumab, were positive trials in that they said that addition of these agents improved outcomes. But the Alban trial, which is the atezolizumab, was negative. So the medical oncologist here on the panel, why do you think that the atezolizumab failed? Was it that the drug was not successful? Was this agent specific? Is this a class effect? Why do you think this is happening here?
So, sir, there are numerous trials. This is one of the trial, but we have at least 10 examples where, like two PD-1s, Nivo and Pembro, they don't, have the similar data. It also applies to this, there are so many trials where although the class of molecules, atezolizumab and durvalumab are similar, but the drugs are different. So that can be the reason.
Anything else?
So in the atezolizumab trial, even a low-grade recurrence was counted as a failure.
Absolutely.
Which is ideally not to be taken as a failure because you're really worried about high-grade recurrences.
Absolutely. So I think there are two things here. So I think Amandeep just nailed it. So the atezolizumab trial, I'm sure if you look at the subsite, what the atezolizumab trial said is that any failure inside the bladder is a failure, whether it's a low-grade recurrence or it's a high-grade recurrence. They qualified any recurrence as a failure. Whereas the sensalimab, they said that only a high risk, that is a high-grade recurrence, will be counted as a failure. So I think that the atezolizumab fared worse, the trial fared worse because of the way that it was counted rather than an absolute failure of the trial itself. And then there's also this class action effect. The reason that I put it there is that, I'm not the person to say this, the medical oncologist is a better person than me, but the sensalimab blocks the PD-1. So downstream it blocks both the PD-L1 as well as the PD-L2, whereas the atezolizumab is a PD-L1 specific blocker, doesn't block the PD-L2. So we don't know whether, blocking the PD-L1, whether there's a breakthrough action that happens along the PD-L2 pathway that is leading to a little more recurrences in the atezolizumab trial or not. So that is what it is. So in the trial, if the patient comes to you, would you be comfortable using any of the three, or would you just go by the trial and say that atezolizumab doesn't work, so it's going to be either pembro or sansalizumab.
So we have only Durva in India. We don't have sasanlimab.
So if you have Durva or atezolizumab,
we have atezolizumab, correct,
so,
in the country.
So if it comes to the clinic, would you be comfortable using either or only Durva?
I would
The
use
medical oncologist.
Durva, sir, because the data is there, so we will be using the good database.
Primary investigator himself is not using.
Absolutely. So again, so now if you look at the CREST and the Potomac trials, whether you use durvalumab or whether you use sansalizumab, both of the hazard ratios are 0.68, around the same number, 6869 for the DFS or EFS. Neither show an OS benefit. Again, it's an NMIBC, so you won't expect an OS benefit. The hazard ratios are identical. So would you call these regimes as equivalent? And what would you tell the patient today? Would you say that I could use either of them, or one of them, or what would be your thoughts in practice? How would you prescribe one over the other?
Again, availability, but if we did have sasanlimab, it is a subcut injection.
No, I'm saying assuming that you have everything.
Right, so if we do have it in a couple of years, it's a subcut injection compared to Durva, which is an IV injection. So then,
Yeah. I think you can choose any of the.
Either of the two, yeah. So identical cross. We all know that we should not do cross trial comparisons. Identical hazard ratios are not equivalents. But having said that, I think the one thing that I found is I found two things here which would help us choose one over the other. One is the route of administration. The subcute is much better if we have it someday. I'm taking cost out of the factor, just looking at the trial design. The other things that was there was the toxicity profile. The toxicity profile for the durvalumab was about 5 times that of BCG, and the side effect profile for the sansalizumab was slightly higher. So 21% versus 29%. So the grade 3 and the grade 4 toxicity. So that grade 4 toxicity was slightly higher with the durvalumab compared to the sansalizumab. So maybe that could also be a factor in deciding what is it that you choose. Again, I'm just putting these questions around because we've gone through the evidence as it is. So I'm trying to understand what is it that we would practice on a day-to-day basis. I'd request the organizers to let me know when I'm out of time. I can completely stop. So now we've got these two paradigms. On one side, you have the JCOG, which tells us even in the high-risk NMIBC, don't do anything, don't even give BCG. And on the other hand, you have the CREST, the Potomac, and also the Alban trial with all its caveats, which tells us that BCG is not enough, and then you have to intensify BCG. Now, how do you reconcile both of these things into your routine clinical practice, assuming that you have everything, cost is not a factor, you have everything in your practice? One tells you don't even give BCG, the other tells you intensify BCG on top of everything else, you give something more. So what is a coherent practice that you would do, Srivatsan?
I think we have to go on with our guidelines first, do the risk stratification and go with that. At one end, you say high risk, you need not do anything else. On the other end, you say you have to add a drug to an already high risk,
Absolutely.
a drug which has so much side effect, and then claim that both are equivalent is something which is not logical. So I think you have to take the middle path because though I understand the evidence generating by the papers will be analyzed and statistically, but for the patient, you have to go by the guidelines. That's the first point, one. And second point, I think we all know from our experience, though you have to look at the data, that high risk is generally more aggressive. I don't think observation, if you give me the trial and say we will observe all high risk, I wouldn't do that. I wouldn't be comfortable in doing that. Whether addition is something we have to wait for the data to mature to say whether it actually helps it, but I think BCG is the basic minimum that we'll have to follow. Additional is, I think, something we have to discuss with the patient, the additional side effect profile.
I kind of agree with that. Hi, Vivek. So I kind of agree with that. Again, like I said, my sense of the JCOG trial was that that there was a selection bias and that they selected a very super select group of patients for good outcomes. For everyone else, I think BCG is the way to go ahead, or probably augmented BCG, I say BCG with an IO agent. And I think the road forwards going ahead in a few years' time is going to be using and then We've seen that at least in our country, we have generated evidence from my own institute, from Amandeep is here, Dr. Vedang is here from Tata as well, that BCG works as a single agent alone. BCG works and it works very well. So the question really is, who are these patients that you need to add on the systemic immunotherapy? I think the way forward is the ctDNA. The more I read about it, the more I become convinced that ctDNA is probably the way ahead. That is probably going to be the marker, and classifying bladder cancer on the luminal types. That is going to tell us in the future, who are these patients that are going to benefit from addition of immunotherapy to the BCG. Something like what the IMvigor 01 trial is doing. Okay, now coming to the MIBC segment. So the Keynote 905, the EV Pembro trial showed us a PCR of 57% in the intervention arm compared to about 9% in the control arm. So does this finally address the decades-long unmet need? And so is this a once and for all answer? And how do we contextualize that? A lot of these 8.6%, there was a PCR in the control arm as well. The medical oncologist, Dr. Akhil and
so definitely, sir. I mean, EV Pembro in bladder cancer. Now, in cisplatin MIBC, there is a preferred option. The data is very, very strong. Yeah. So, but I'm still, not able to understand why control arm is also having PCR of 8.6%. So I just need to see which was the control arm in this trial.
So the control arm is probably the PT0 after TURBT,
yeah,
right?
Absolutely. So the control arm is probably all those patients that had complete resection of all tumor and had no microscopic disease left behind at the end of it. Again, a question to the medical oncologist, Dr. Arshit and Dr. Akhil. So we know that in the trial that had the dose-dense MVAC, the total dose of cisplatin that was given was much higher compared to what is routinely given for the GEMSIS trials. So every addition that we are doing, and the VESPER trial showed a 9% benefit, additional benefit of using the DDMVAC over just using GEMSIS, which is around the same quantum of benefit that you get by adding all the immunotherapy drugs also that you have. So the question to the medical oncologist here is all the immunotherapy that you are giving only compensating for inadequate cisplatin that was given in the VESPER trial?
I think Akhil sir can.
The total dose of cisplatin was much higher compared to the ordinary GEMSIS that you give.
So basically, we must understand.
Again, this is me putting on the medical oncologist hat, so I'll completely agree with everything that you say.
So basically, we must take into account, like in radiation, no treatment is radio resistant if you are able to give sufficient doses. In medical oncology, if you are able to give too high doses, but at the cost of significant toxicities, so nothing is untreatable.
30%, 40% reduction of incidence of hepatitis in EV Pembro.
Yeah, but I am telling that if you are able, we are giving 200 milligrams of cisplatin in every cycle, definitely there will be good responses, but that will be intolerable. So we have to utilize a treatment which is tolerable and actually utilizable. DDMVAC, we started using it, but we had to stop due to significant toxicity. Nearly every third patient required admission for management of toxicities. Otherwise, when the VESPER trial came, we started utilizing. But again, we had to go back to the usual GEMSIS. So it is balance between toxicities and benefit that is important. It is not that immunotherapy is compensating for the inadequate doses of cisplatin. It is not inadequate. That is tolerable doses in our settings. It might be higher doses might be tolerated in some other settings where the toxicity rates are lower, patients are more fitter. We can choose the patients accordingly.
Thank you.
Sir, in VESPER trial, they didn't include any node positive patients. In this trial, they included node positive patients, and almost more than 80% of patients are more than stage 3, almost stage 3 patients. It's not the case in VESPER. And the paths here, should not do cross trial comparison, but here it's almost 60%, where it's almost, I think, 35 to 40%.
Anand, can I ask a provocative question?
Yes, please.
When you and all of you see operate and see a path CR on a cystectomy, do you feel happy or do you feel sad? And why? Or it's a mixed.
So again,
So
this is
we can start with you, and then maybe we can.
So
it's an important issue.
The best part about being the moderator is I can open it up for the panelists to answer, and then I can say that I'll give my final comments. So be that as it may, again this is my personal opinion, and I may be wrong in this. I may be completely wrong in this. I think for a lot of the neoadjuvant trials that we have in oncology, I think the benchmark for neoadjuvant trials should be overall survival. I think we use PAT-CR as a surrogate marker, and we keep using PAT-CR. The PAT-CR in this is better than the PAT-CR in there. So be it. How does it matter? What matters is that does the PAT-CR for all group of, irrespective of whether you reach PAT-CR or not, for the group of patients that you've given one line of therapy compared to the other, do these patients live longer or not? Whether or not they reach PAT-CR is, it's good to have PAT-CR, but if you did and you lived equally longer as well, that would be equally, that would be the question that I would be looking at. PAT-CR, if you get it, I'm happy, but if you lived longer, I'll be even happier. That's the best answer I can give you. I open it up to the floor. Absolutely.
Not for local control is not the priority.
Absolutely. So the neoadjuvant space again, I think is used everywhere today, but the way again, I feel very intimidated, talking in front of the medical oncology crowd here. But the way that neoadjuvant therapy originally was given only for two reasons. One is you had an inoperable disease and you had to downstage it to make surgery better or feasible, and you had extensive disease where even if you operated and there was a delay in treatment, it could lead to inferior survival. So that was the intent of neoadjuvant chemotherapy, not PAT-CR. It is just an incidental finding.
So let me rephrase. The bladder is sacrificed. Do you feel it is unnecessarily sacrificed? Now that was the question. Because no, but there was nothing there. What do you mean, so what? That is the only point. Yes.
Sir, so
do you feel bad to radiate those bladders?
I'm saying do nothing.
Exactly. Sir, so
Because we removed the bladder, we'll use that.
yeah, so the thing is we feel happy because that is probably the only benchmark we have as of date. But we do feel bad because that bladder probably could have stayed inside the body without any further local treatment. And probably 10 years later,
And
it is
this
going
is
to happen.
going to be more and more.
I agree with you on the question of whether the bladder could have been left behind. I think that's a wonderful question to ask. But as of date, we lack tools that tell us that even if you've done a complete TURBT and there is no disease left behind inside the bladder, whether or not there is microscopic disease left behind or not, or if you had some disease inside the bladder and you gave neoadjuvant chemotherapy and everything disappeared, those 40% to 50% that had PAT-CR, 57% had, where is the PAT-CR rate? Sorry, 57% that had PAT-CRs. There's no way of predicting who of those 57 were. So it's a matter of time. Maybe 5 years from now, there could be a tool to predict the 43 versus 57. Maybe at that day we could answer.
Or you should have a mechanism where you take it out, check it out, and then put it back in.
Bladder transplant, auto transplant.
And you occasionally see patients who are YP T0 but still N+.
Yeah.
And yes, so
See, ultimately, I think we are moving to a non-surgical or non-local. Bladder cancer might be a medical disease in next 5 to 10 years. That we don't. But as of now, we don't have an answer. Sorry, sir. Yes.
I think we'll only remove bladders who have not responded to systemic therapy.
So I think we're completely out of time. I think we had a lot more questions to do, but maybe at a later date. Thank you so much. Right, so the next question was again on the BART trial. So the BART trial showed us that adjuvant therapy reduces loco-regional recurrence after cystectomy, and the UCG trial showed us that nivolumab plus TMT reduces distant metastasis. So how, I mean, put together, what do you tell us, what does this tell us about the failure patterns of MIBC? And then this UCG trial, is it something new? We already know from the Checkmate 274 that if you add nivolumab after cystectomy, those patients live longer. You're kind of just extrapolating that to say after local therapy, whatever local therapy that is, cystectomy or definitive radiation, you add nivolumab and these patients live longer. So am I correct in interpreting that? And how do you, I mean, what does this tell us about the patterns of failure and practice in the real world today?
So locally advanced bladder cancer, node positive, all the BART-like patients, a lot of them have distant metastasis. It was really sad to see so many patients failing distally when we are doing so much loco-regionally, big surgery, this is all in spite of 90% getting cisplatin-based neoadjuvant or adjuvant chemo. So I think that is the biggest, lowest hanging fruit is to reduce the distant metastasis. And there is no question we have to do immunotherapy. That's proven. So that has to be reduced. Whether that will have an effect on the 25-30% loco-regional relapses, we don't know. It is probably unlikely. So my view would be that both have to be done. A lot of the patients don't get immunotherapy either, certainly in India. Even with nivolumab and other things becoming generic, many will not get or will not be able to take. So I think we must bring in the adjuvant radiotherapy and add immunotherapy for a year. I think that is what we should do for most of the patients. And the magnitude of benefit, even the 3-year disease-free survival, overall survival, it is matching in the test arm to the Nivo outcomes.
So there you have it from the horse's mouth. There's nothing that I can say that will add to everything that Dr. Vedang has done. I think he's done a brilliant trial. So yeah, please.
So on one side, we are saying this systemic therapy or peri-op immunotherapy may not improve loco-regional failures.
I am not saying that.
Because it is basically systemic control, not the local. But on one side, we are saying nearly 57 to 60% path CR. Means locally it is acting. So should we consider radiation for every patient? Are there any particular subgroups we can classify and give only for those particular group of patients?
Yeah. So we don't know how to interpret post-op adjuvant any treatment with EV pembro or pre-op IO. I mean, all of this becomes little iffy. So if we are doing more and more pre-op IO, then I don't know how to interpret this,
Absolutely.
any of this.
Do we have time for one more question or are we done? Yeah, so we know that post-TMT ctDNA predicts metastatic recurrence, but it has zero sensitivity for local bladder recurrence. So what are the clinical, implications of this dissociation, that if you do ctDNA, you might have a metastatic recurrence can be predicted, but you can't predict a local recurrence if it happens, doesn't happen. So what is it that you will do in your routine clinical practice? Will you say that cystoscopy not to be done, when to be done, how to be done, and the ctDNA when to be done, how to be done? What is it that needs to be there?
We have very little experience with using ctDNA. So assuming that we get it and we do it for patients who have, we are doing actually a study to standardize ctDNA at our institution. And Akhil tells me that we have recently had access to something from MSKCC also. So I would, based on this, I think scopies are required. I don't think we can do away with the scopies. What else? Aman, anything else?
If somebody ctDNA is positive, no, it does not matter what is happening in the bladder.
Absolutely. I think I'll just come to that. I think again, Amandeep is a rock star today. He's just nailing it on the head, left, right, and center. I think we need to complement.
But I'm not. Sorry.
Yes,
So
please,
if
please,
somebody
please,
ctDNA is positive, no, I don't have no point in scoping, but if there is still something on scopy, I'm not sure if doing a TURBT or taking out that bladder is affecting OS for that patient.
I don't know if you can see, there's some fire going behind Amandeep today. He's on fire today. So I think that kind of nails it on the head. I think cystoscopy is indispensable. Cystoscopy and ctDNA are complementary. In that cystoscopy, the ctDNA has got zero sensitivity to predict a local recurrence. So you need cystoscopy to predict a local recurrence, and you need to do ctDNA to predict a metastatic recurrence. Probably the MVigor trial will probably tell you that maybe patients who have ctDNA, whether you could have early initiation of systemic therapy. But the way that I would use it in practice is this data is what Amandeep said. I would do a scopy for sure, at the first instance. But if the ctDNA was positive, I'd probably focus a little bit more on the system.
But Anand, what you are discounting is you don't know when that will come.
So there is data to suggest that if the ctDNA is positive, there's a 9-week delay. In about 9 weeks to about 10 weeks, you will have manifest disease somewhere.
Okay.
So the data is that in patients, from the time that the ctDNA becomes positive to the point of developing overt metastasis, the time lag is about 9 to 10 weeks.
Then it makes sense. Yeah.
Then, and if subsequent ctDNA shows negative, are we stopping systemic therapy?
I think you can ask to the other medical oncologists on the panel. Okay, thank you so much. Yeah.
Can I call on Vaibhav to conduct the next panel? The panelists are Dr. Akshay Karpe, Dr. Arvind Vaidyanathan, Dr. Samir Srirangwar. Thanks.
Yeah. Welcome all my esteemed panelists, and I think in the interest of time, we will just start with our agenda today. This is a moderation sponsored session, obviously from Astellas, for the role of enfortumab vedotin in relapsed refractory bladder cancer. Now we have been hearing about enfortumab vedotin and its synergy with Keytruda and stretching up to the neoadjuvant horizon. And this is where it all started, from the second line, third line essentially, where metastatic bladder cancer patients would have progressed on platinum-based therapy, would have progressed on immunotherapy, which was an option. And this was a subset of patients when there was no standard of care. So this is keynote 302. We'll discuss and the revolve our discussion around that. There is a reason why we are discussing this, because yes, it's an unmet need. Second, till now, Astellas has only got permission for marketing this in second line, third line onwards. Very soon, we are expecting the approval in the first line as well. And neoadjuvant data looks very lucrative. That is up for grabs. So, this is the disclaimer. We know what EV is and what the ADCs have done to the advanced urothelial cancer. We will not waste time on that. Yes, this is EV301, compared efficacy with chemotherapy in patient with previously treated locally advanced metastatic urothelial cancer. And good study, 608 patient. ECOG PS01, disease progression after, during or after PD-1, PD-L1 inhibitor treatment. That was prerequisite. And prior platinum-based chemotherapy was also a prerequisite. This is how essentially we used to treat bladder cancer, I think 4 or 5 years back. Now, and they were randomized 1:1 into EV or chemotherapy of physician's choice, which obviously was docetaxel, and we have paclitaxel there, vinflunine, and pre-specified interim analysis was conducted after 65% of patients had died. Primary endpoint OS, because this is a setting where obviously survival is not expected too far, and that's why the primary endpoint in these kinds of trials is mostly OS. So coming to, so this is the baseline demographics, just an overview of the study. OS benefit, yes, they did hit the OS benefit with a median OS of 12.88 months versus 8.97 months. And due to significant improvement in the OS, overwhelming response with as compared to chemotherapy, EV301 permanently stopped. And that interim analysis, and that actually is a very positive sign or signal for any drug to come into the clinical picture, because it just shows beyond doubt that this drug is effective in this kind of particular type of tumor. Across subgroup, this was maintained. So yeah, PFS again benefit was there, 5.55 versus 3.7, again significant, and across subgroups again. So all, even in the elderly, more than 75% of age group population was also there, and they also seem to benefit from it. More important things to take in context before we actually turn to our panelist is overall response rate. Remember, the overall response rate is in third line. It is those who have progressed on platinum-based chemotherapy, those who have progressed on immunotherapy. Despite that, there are 40% of overall response rate, almost 72% of disease control rate. Time to treatment response, again very short, 1.87 months. And duration response are almost 8 months. So very good numbers, and across subgroup, everything across subgroup. So quality of life not impacted poorly. In fact, seems to be better than chemotherapy in the end. And yes, again, longitudinal comparisons of quality of life parameters again did show that at 12 weeks changes from baselines was good. So EV maintained baseline QOL with less variability versus chemotherapy assessed over 12 weeks and meaningfully improved most quality of life domains. Now, these are the key takeaways. Median OS is higher, PFS is higher, ORR is higher, and the quality of life is also improved. So after this, I think all of us are in consensus. We can conclude the session and agree that there is no point for discussion. But again, we live in our India, right? And EV, which has been launched quite late. Remember, this is not a new trial. This data we are having since 21-22. And since the drug has come in now, we have got access, and we would just like to point out pointers where this drug has some place here in this scenario. And if we have a good handling of this drug, and then we can manage the side effect profile and all, I think there is lot and much to discuss on how to handle this drug. There is no doubt about the efficacy point at this point of time in this particular scenario. So we'll revolve our discussion around that only. As we see, starting from the cisplatin thing and the carboplatin thing, I would just like to ask Dr. Ashay Karpe, in your practice, do you believe in cisplatin versus carboplatin, which is better in metastatic setting, I'm asking?
So even if you look at the data, almost the PFS and OS is almost half as compared to, not half actually, but at least almost 2/3 as what you see with cisplatin. But definitely when you look at the patient profile, most of them will turn out to be cisplatin ineligible if as this juncture, because as you said, rightly pointed out, this data is old. Now I don't think if I have to offer enfortumab, it will be third line. So the thing is that if my patient cannot go for probably immunotherapy combination and I have been cornered to give chemotherapy, and it's cisplatin ineligible because of the renal dysfunction, that's the only place probably I'll put carboplatin.
Right. Dr. Samir, treatment options in second line for advanced urothelial cancer, we are looking at two scenarios. One, who are platinum eligible or chemotherapy, you are given chemotherapy and then patient has progressed. Or another option, platinum ineligible, patient has no issues with no cost constraints. We have given immunotherapy in the first line. Both the scenarios, your take on the second line right now.
So in first scenario, whether patient is platinum
Eligible and has taken.
So,
Yeah.
so patient has taken chemotherapy. Then the question arises whether patient has received along with that immuno or not. So the patient has received maybe maintenance sabilumab or maybe Nivo, Gemcis Nivo, which both are the standard of care option right now. In that case, when the patient has progressed, the next option would be EV only. If the patient has not received immunotherapy in the first line, then we have option of using immune checkpoint inhibitor second, and then third line we can use EV. So right now we don't have data for EV in second line or third line whether patient has not received immune checkpoint inhibitor.
Right. So this is according to this data, as we see the response rates and whatever, if you compare EV in third line, response rates are actually better than the overall response rates of first line of immunotherapy alone. So yes, I think that combination, which turned out to be very, very good, has changed the picture completely. And this kind of a discussion is actually dated. So yes, second EV, there are multiple places where you can put EV. 3 scenarios here. Where someone is ineligible for chemotherapy, has got PD-1, PD-L1 inhibitor and has progressed. Then second, platinum-based plus available maintenance, as you pointed out. And the third one, where subsequently he has received 2 lines and then EV. So this is what is basically the place of EV and what has been registered here in our country, and we are getting support program for that, because without support program, the cost issues actually take over. Coming to the clinical case, this would be a typical case of 78-year-old lady where she has an unresectable locally advanced urethral cancer. Gemcis was given, and then switch maintenance for avelumab as a standard of care. Has some comorbidities like diabetes, fatty liver, and moderate renal impairment. And concomitant medication is metformin only. So at this point of time, post progression, what would be the options out of 6? What would you choose and why, Dr. Ashay?
So as we are looking at it, now if you look at the way she has received the chemotherapy, then immune checkpoint inhibitors, probably the most valid option is EV. But we have to look at the patient demographics also. What exactly? And the thing is that she has a diabetes. So again, I would like to know whether it is a controlled diabetes or not. Second is a liver dysfunction. And third is definitely, she's on metformin, so CYP3 inhibitor. So all these things, but absolutely these are not the contraindication. And looking at the creatinine clearance again, which is 34. So again, I think if I look at all other options, probably I'll be more inclined towards EV.
Dr. Arvind, 78-year-old lady, already been through chemotherapy, already been through immunotherapy. Do you go for best supportive care or something more EV again? It is full of side effects. It is not free of side effects. I would rather say a lot of people's skepticism around enfortumab vedotin initially was because of skin toxicities, diabetes control and all. And we learned to manage these toxicities eventually. So what would be your policy here for such patients? You will have a conversation about EV or something else or a single agent chemotherapy? What is the thought process?
I think it depends on the patient fitness. We should only not just see the age. We should also see her physiological age. If she's 78, she's fit. If she's PS 1 or 2, I think we can definitely offer her systemic therapy. If she's PS 3 or 4, then likely best supportive care. And among the options, I agree with Dr. Ashay that EV is the best option among all the others because it is better than the other chemotherapies as shown in the trial. And mild to moderate liver or renal dysfunction is not a contraindication. And even there are not much drug interactions. So these things are not going to be contraindications to give EV to this patient.
Right. What are the strict contraindications for giving enfortumab vedotin, Dr. Ashay? Where you would be concerned and what is absolute no-no?
See, if I'm looking at the absolute contraindication is only the hypersensitivity to the excipients of the drugs. That is the only contraindications to this drug. But otherwise, somebody having, even if you read the literature, though there is even end-stage renal disease and other things, though not safety acceptable, but even if there is a data, like those patients who are especially on dialysis, you can give enfortumab. It is not that like strict contraindications. So I think barring this, I will, what are the other riders are mainly, looking at the various side effect profile, the cutaneous, the liver, the hyperglycemia, and ophthalmic side effects. So I think these are the certain things which I will look at, and if it is a well controlled, I don't think so it is a very serious contraindications.
Yeah, Dr. Samir, in this particular trial or other trials of EV, the cutoff for inclusion criteria, the HbA1c of 8 was there. When ultimately we are the diabetes capital of the world, patients come to you and get diagnosed diabetes simultaneously with cancer a lot of times, and their HbA1c is skyrocketing. What is your strategy at that point of time?
I think nowadays we have like multidisciplinary board available with us, so we can get involved any diabetologist in the team, and we can ask the patient to get a consultation done and get the sugar control done. Then we can obviously start with 1 or 2 weeks time. We can monitor the patient properly.
So HbA1c of maybe 10 has come to you, and was in your opinion she was inadequately treated. So would you deny EV, or would you give some time for management and then start with it?
Some time for management, control the sugar, and then start.
What would be your cutoff? What would be your cutoff for HbA1c or a poor diabetic control?
HbA1c reflects the long-term control.
Yes.
So even if she comes with HbA1c 10, we can initiate her on OHAs and insulin. HbA1c will not come down, but once the fasting and postprandial comes down below 240 or 250, then we can initiate it.
Right. And I believe, Arvind, you must have used it in your institute EV. What has been the experience like? And everything boils down to dosing. So what dose you are comfortable with, and what has been your experience?
So there are toxicities. We start with the standard 1.25 mg per kg, but I think the neuropathy is a problem, skin reactions, cytopenias. So in case there are recurrent toxicities, we have reduced it to 1 mg per kg and 0.75 mg per kg, which are better tolerated than the full dose.
And still effective?
Yes, sir. It has been more or less effective. We see patients having PFS of at least 5 to 6 months. So even the reduced dose seems to be effective.
Because this is a scenario where I don't think you are spoiled for choices. There are no other contenders.
Absolutely, yes.
Especially typically, if you are asking about this particular thing which we are discussing today, that we are done with everything, either it is best supportive care or a trial of EV. Yeah.
Only options remains FGFR inhibitor and it is HER2 positive.
Yeah, that mutation thing is a different, yeah. But again, FGFR inhibitors, are they available? Do we have access?
My question is different. What is the best response you have seen with the FGFR inhibitor?
Yeah, that also is. Yeah.
Still, efficacy wise, definitely EV is better than other two.
Right. So we will actually try to manage if a little bit of diabetes is there, some renal impairment, hepatic impairment, age. Again, as we showed that there were patients in this particular trial which were 75 years and all. So not big deal. Basically, we are all physicians. We are well versed with managing the side effects as well as the baseline characteristic. And the good thing is no biomarker testing is required. The immunotherapy world revolves around the biomarker and the search of biomarker, and the response rate, they blame it on lack of biomarker. But ADCs, on the contrary, this EV seems similar where with other ADCs as well, that no biomarker is required regardless of the Nectin-4 levels. But does anyone is doing Nectin-4 levels and all in your institute or anywhere you have seen?
We are not doing.
But it doesn't have any value, and for all comers this is there. Yes, diabetes I think we have already discussed. We should actually look at whether we have made sufficient effort to control diabetes or not, rather than writing off such patients, because invariably our patients will be having comorbidities. Right, impaired renal function, I think we have already discussed. GFR was less. Any concerns, Ashay, with GFR?
The patient, even with there is no data because they have not included end-stage renal disease, but even if somebody is on a dialysis, still you can go ahead and give EV.
So we have actually started the patient on EV with strict glucose monitoring, and yes, she has received the 5th cycle and grade 1 peripheral neuropathy, sensory neuropathy. Now, what to do? Dr. Samir.
So grade 1, I would continue with monitoring. Only if the patient develop grade 2, then we stop it. We allow the patient to get the neuropathy to resolve to grade 1, and then again we start with the same dose. But if it is recurring, then you have to reduce the dose.
Right. How many have landed up with peripheral neuropathy? Arvind, in your setup?
Yes, I have seen 2 patients who had peripheral neuropathy, but it was grade 1, so that was manageable. But
That was manageable.
Definitely, in case of higher grades, we will need to interrupt the treatment.
Right. So from grade 2 onwards, there are particularly yes moderate symptoms limiting the day-to-day activities. We actually are not justified in continuing it. How many did have neutropenia or cytopenias and all in whatever patients you have given, Arvind? Was it a concern?
That was a concern, especially one patient who was pre-treated. He was on third line, and with the first cycle only, he had cytopenias with febrile neutropenia. So we had to reduce it to 1 and then 0.7.
You were able to maintain.
Yes.
Ashay, would these things, heavily pretreated patients and all, deter you from giving ADC, or you will initially start with a lower dose?
So I think definitely there is no data to support it, but the only thing I just wanted to point out now, you have recently palbociclib, So now they are saying even the lower dose, even if you're using 75 mg, rather than have a frequent, what I can say, breaks in the therapy, probably it will be, prudent too. But again, there is no data to support it to start. But yes, in many of the situations, we take this call and we start with the lower doses, which we are doing with other ADCs also.
Right. Very elderly patient. Yeah.
When the cost come down.
Now you have come to the point.
Cost doesn't go down like that.
That was I was actually coming to. So in a cost constraint scenario, you don't have any choices. The 1.25 mg per kg dose is costing way beyond 2 lakh rupees.
30 and 40.
So have you done that? Have you started with lower dose? That's what I'm asking.
Consider one patient to take. If the dose was around 50, I told them to get 40 only.
So do you, right. So ultimately we have to, I think Arvind will throw more light on that. In such situations, what do you do?
So cost is the main issue. In our setup, it's a government setup. So most of the patients will not be able to afford EV. So definitely cost is there, but then they are offering the PAP also. That helps a lot of patients. But ideally, I would like to start at the full dose.
Yeah, ideally we should start at the full dose, but seldom we get a textbook patient like this trial who is very fit for trial and all. Some of the other comorbidities will be there. I struggled with diabetes, peripheral neuropathy, renal, everything, all sorts of, even borderline PS. So first patient I started on EV. Again, I started with 1 mg per kg rather than going to 1.25 because multiple factors I took into account. It is kind of a personalization. It worked. It did work. That was a different setting, first line with Keytruda, and there we actually, that's not the point of discussion today. But here again, if patient has been through 2 lines of therapy, cost becomes of paramount importance. And to bring down the cost, yes, Astellas has done a great job by giving a good support program. We actually need more for such kind of patient. Typically, those are relapse refractory and they don't have third line onwards and all. So here financial status is quite thin. We can work around that, but in this panel we restrict our discussion to the point that even low dose might be effective in ADCs, like routinely we have seen in other perspectives like breast cancer, HER2 and all, the lower doses do work. So that science is there with you. And one last, I think in the interest of time, we will just rush through that. One burning questions like Ashay, coming to the future scenario, like this is there, but if someone has taken immunotherapy in the adjuvant setting, right, and then patient has progressed, will it be justified to give them immunotherapy in the metastatic setting? And like for example, adjuvant setting, Nivo has finished, and then patient has become stage 4. What would be your treatment of choice then?
So see, the thing is that if you look at the immune checkpoint inhibitor re-challenge, so there are certain things where, so what were the previous responses, with the immunotherapy, whether it was a complete response with the immunotherapy. Second thing is that the duration of the response, was it more than 6 months? Maybe third thing is that you could finish off the immunotherapy previously and then it was relapse, maybe standard we give sometimes 2 years plus. So if that was the scenario, definitely I'll be more inclined. But if there was a hyper progression on immunotherapy, or there was not much duration of the response, or what response had was stable disease, I'll be skeptical to use immunotherapy. But if the whatever the first 3-4 things I said, if the answer is yes, I won't mind combining again immunotherapy. So definitely there is no again, so if probably you have used anti-PD-L1, then might be anti-PD-1 you can use. But when you are re-challenging with immunotherapy, the responses are low as 12 to 13%.
Right. Samir, coming to this same point, patient is on adjuvant nivolumab and has progressed on adjuvant nivolumab, what would be your treatment of choice? Will you entertain enfortumab vedotin somewhere?
Yes, but we don't have any exact data cut.
Yeah, so these trials are old.
So
Yeah.
after 1 year, I will surely
Not
re-challenge.
My question is different. Someone has progressed on nivolumab,
Progress
adjuvant
for-
nivolumab. Adjuvant nivolumab patient is taking and has progressed after 7 cycles.
Then in that case, no. I would give only EV.
Arvind,
Yes, I would give EV, definitely.
you will give EV?
Yes.
With Keytruda? No.
If it's on immunotherapy progression.
Yeah, doesn't
then
make any sense.
only
Perfect.
EV.
Doesn't make only EV and then give it. I think that's a kind of a gray zone. But yes,
There will be a scenario whether it is like oligoprogression, only 1 or 2 lesions are there.
yeah, that is a different
In
discussion.
that case,
Yeah,
can be think or, but it's a florid progression then.
yeah, if florid progression. Point well taken. Thank you. Thanks a lot for patient listening, and thanks all my panelists for expert comments, making this thing worthwhile. Thank you. Thank you.
So by the time we are settling down, may I have a pleasure to request and invite Dr. Shivam Singla sir on the dais, and sir is going to do an interesting talk on the new paradigm in the management of advanced urothelial carcinoma. So over to you, Dr. Shivam sir.
Thank you, Tarunji, and thank you, organizers, Ashay, Vivek, for this opportunity. So this is a sponsor talk by MSD. We had a fantastic session on the the panel discussion. So just a brief overview of management of advanced urothelial cancers. The Keytruda also is one of the viable options. So these are my disclosures, and the slides have been provided by MSD. So when I talk about urothelial cancer, the incidence of urothelial cancer is increasing. I think this is a jargon which we have heard many times, but what is interesting is that all said and done, we do see a lot of urothelial cancer patients, especially patients who have been smoking, who have been in industry for paints, and some sporadic cases. They tend to present early, but if ignored, there are cases which have progressed over time from non-invasive to invasive. So globally, the incidence of urothelial cancer is somehow higher in men, 4-folds higher in men than in women, and we see about 5 lakh cases a year globally for urothelial cancer. If you look at the registry, Delhi tops in males and females percentage of patients developing cancer, and then you have a fair number of patients in Mumbai as well. In India, however, this is the 17th most common cancer because head and neck and cervical cancers continue to be one of our major reasons for mortality and morbidity. The projected numbers are bound to go up every year. Cancer incidence is going up, unfortunately. We are getting more and more occupied as medical oncologists. Males significantly higher than females, but the way smoking is increasing in females, I don't know what the future holds for this country and for the rest of the world. Staging of urothelial cancer, 2 types. One, you look at the grade. One, you look at the depth of invasion. And once the tumor invades the muscle, I think then the patient is doomed, and we have to do extensive removal of the bladder, the radical surgery, and then the patient requires chemotherapy. Before muscle invasion, local treatments would suffice. The survival has improved over a period of time. You can see from 71% to 79% in 2011. It has even gone up globally because of the access of better drugs available for the improvement of survival in urothelial cancers. But the survival of distant metastatic urothelial cancer is still pretty dismal at 6.4% in US. So you can imagine what the situation would be in our country. This is an academic slide where you can see that low risk, you just do a cystoscopic surveillance. For an intermediate high risk, you can do a onco-BCG administration. You can also administer gemcitabine. Onco-BCG is not available recently. Very high risk recurrent BCG unresponsive, we do cystectomy in such patients. But once the muscle invasion happens, it is chemotherapy followed by surgery and then the follow-up. In terms of systemic therapy options, the first line is a platinum-based regimen, Gemcis, Pembro, Atizo, Durva, maintenance, EVI. Second line, you have Pembro or Adrafitinib, and third line, you have EV, although the first line data of EV Pembro also does exist. Intravesical BCG for non-muscle invasive. And the prognostic factors which would lead to or decide the survival, pretty simple: ECOG, liver involvement, or hemoglobin. So as more prognostic factors you will have, poor prognosis, the outcome is poor. So liver metastasis and low hemoglobin generally means a poor prognosis in such patients. Second line treatment options, barely anything works. The overall response rates are pretty dismal, 0 to 28%. The OS is about 7 to 8 months. Few small observational studies, combination studies, but the outcomes are generally poor. And people have tried Vinflunin, Gem Paclitaxel, Gem Citabin, Cabazitaxel, but nothing really works, very good in the second line option. So the old era was chemotherapy, and then there was nothing much till 2006. Then Vinflunin came with an RCT, and then now things have changed, and we have moved to PD-1, PD-L1 inhibitors, and there is a substantial data to say that we've reached there. How immunotherapy works, I'm not going to spend time on this. So just quickly, last few slides of my presentation, the Keynote-045 trial. This was a second line randomized trial for Pembro versus investigator's choice of Paclitaxel or Vinflunin, and they looked at the ORR and DOR. So this was the enrollment dates: 2016 started, data cutoff 2017, median follow-up of 27 months. Substantial number of patients enrolled, 542, 270 roughly in each arm. Well represented trial, PDL1 positive patients, hemoglobin less than 10, poor prognostic patients. So the key follow-up is that at the median follow-up of 14.1 months, pembrolizumab was effective with a p-value of 0.002 with a hazard ratio for death at 73. So 27% risk reduction in death with doubling of the overall response rates, and median duration of response not reached. This was published, Keynote-05 trial was published in 2021 in ASCO, and at that point of time, all the patients were enrolled, and the OS data was mature. So at 3 years, 20 months, 20% of OS versus 11% of OS in the chemotherapy arm. So almost double of OS without the cytotoxic chemotherapy was quite encouraging. Again, irrespective of the subgroup analysis, the intervention arm was favoring the benefit to the patient. Same thing, PFS, intention to treat population, almost double. You can see the curves are quite attached to each other, but the patients who start responding, they continue to respond. So introduction of immunotherapy helps certain subset of patients who continue to respond. Again, duration of responses almost double. Responders were taking the treatment for a longer period of time. And overall survival with complete response, the patients who had a complete response or a stable disease, they continue to respond for a longer period of time. Side effects, again, nothing we've not been used to. I mean, something which is very easy and simple to understand. You get a lot of side effects related to immune-related side effects, but the incidence of anemia and other chemotherapy toxicities are not there. So fairly safe drug, lesser side events happening towards the left-hand side of the graph. I think NCCN does, recommend as a category 1 recommendation for a second-line metastatic urothelial cancer based on the Keynote-045 trial, and then it also suggests to look for FGFR mutations in the subsequent lines or EV in the subsequent line if not received earlier. So conclusion, the OS is improved, the response rates are better, and the duration of response is substantially higher, 29.7 months versus 4.4 months. It's a safe drug, and this data is consistent with the second and third line follow-up analysis. In terms of quality of life, last two slides, it's a safe drug. We know that patients would prefer immunotherapy over chemotherapy any day, and the p-value is very significant, and the quality of life is preserved, well preserved in the pembro only arm. The scores are pretty good for pembrolizumab. We know that. I'm not going to spend time on this. And the proportion of patients, they felt that they improved significantly higher in the pembrolizumab arm. Significantly higher in the pembrolizumab arm. So pembrolizumab is associated with better quality of life. It prolongs the time to deterioration in quality of life as compared to chemotherapy, and it has a better OS and lower treatment-related side effects. So we may choose going to pembro over chemotherapy in second line if not received earlier. With this, I would like to end my talk, and I'm open to questions if there are any. Thank you.
So thank you, Dr. Shivam sir, for such a wonderful presentation. Now we are moving forward, and it's a great pleasure to welcome and invite on the dais the respected chairpersons for the next session. May I have a pleasure to request Dr. V. Kannan sir. Second, we request you to please join on the dais. To co-chair, may I request Dr. Vanita Norma ma'am to please do. Okay, so may I request Dr. Menet to please co-chair. And we also have a pleasure to request and invite Dr. T.B. Yuvaraja sir on the dais. And may I request the respected chairpersons to start the proceedings for the next session.
Welcome, and we have 8 presentations. I think one of the presenters is not there. So mainly on systemic therapy, something on ctDNA, and also one SBRT article presentation. So we invite Dr. Deep Vora to start the first presentation.
So good afternoon everybody. I am Dr. Deep Vora. I am a consultant medical oncologist in Mumbai, and from advanced urothelial cancer let us move on to the early stage MIBC. So today I am going to discuss about EV plus Pembro, that is EV304 study or keynote B15, perioperative pembrolizumab plus enfortumab vedotin in cisplatin eligible MIBC. So background, the standard of care treatment for MIBC would be radical cystectomy, but only with radical cystectomy majority of patients will do have relapse. So there came the use of neoadjuvant chemotherapy, that was almost 20-25 years ago. Since then the cisplatin has been the king of the neoadjuvant or adjuvant platinum based therapy. So, but even after cisplatin, there was almost nothing major going on in this space. It was neoadjuvant systemic therapy with cisplatin-based chemotherapy, and yeah. So then slowly in last couple of years, new immunotherapy started coming. So first it was immune checkpoint inhibitors in adjuvant setting. They started having better outcomes in form of adjuvant nivolumab or perioperative durvalumab. So these were these two studies. Meanwhile, also we started having use of enfortumab vedotin in the later lines of treatment. So we already discussed EV 301, 302, 303. There are other studies of EV where slowly now EV plus Pembro has become a standard of care for next line of treatment, first line metastatic setting, as well as in first line cisplatin ineligible MIBC, that is muscle invasive bladder cancer. So that is where the EV Pembro was also developing, And ultimately from that we come to a point where we are going to discuss today about, we are challenging the cisplatin in the first line in MIBC setting. So this is the neoadjuvant and adjuvant enfortumab vedotin plus pembrolizumab for MIBC who are eligible for cisplatin. So randomized open label phase 3 multi-center study. Patients were muscle invasive bladder cancer T2 to T4 with or without N1 disease. Most of them were urothelial histology. They were eligible for radical cystectomy and pelvic lymph node dissection. And they were given enfortumab vedotin 1.25 mg per kg day 1 day 8 for 4 cycles with pembro for 4 cycles versus gemcis for 4 cycles. That is standard of care that we use. After that they underwent surgery, that is radical cystectomy with pelvic lymph node dissection, and after that in EV pembro arm, EV and pembro were continued for 13 more cycles of pembro and 5 more cycles of EV. In observation, in the control arm, the post-surgery treatment was either observation, nivolumab was permitted, but at the time of the study design, nivolumab was not standard of care in adjuvant setting. But it was permitted if allowed by the country at that point of time. The primary endpoint was event-free survival. The secondary endpoints were overall survival as well as pathological complete response rates. So almost 808 patients were enrolled in the study, 405 patients in EV arm, EV plus pembro arm, and 400 patients in cisplatin and gemcitabine arm. Out of this 405 patients, 403 started neoadjuvant therapy, 344 completed neoadjuvant phase, and 59 discontinued in between. 351 patients did undergo surgery, out of which 346 had complete resection of the bladder. The 52 patients who did not undergo surgery, the majority of reasons were either participant withdrawal from the study or adverse events. Out of those who underwent surgery, 262 started adjuvant phase treatment, out of which 20 had completed. So 89 underwent surgery but did not start adjuvant treatment, mainly because of previous adverse events or participant withdrawal from the study. In cisplatin arm, out of 400 patients, 396 started, 360 patients underwent surgery, and 37 did not undergo surgery. If we talk about the results, before that the baseline characteristics, both the arms were more or less similar. Majority of patients were T3, T4, PDL1, irrespective, both arms were similar and it was irrespective of PDL1 status. Create clearance also was similar in both the arms. And now we come to the results. The median EFS was not reached versus 48.5 months with the hazard ratio of 0.53. So there is definitely significant improvement in EFS with EV plus pembro in comparison to cisplatin. If we look at the 1 year and 2 year EFS, the difference is almost 11% at 1 year and 13% at 2 years. If we look at the subgroup analysis, most of the subgroups did well with EV pembro in comparison to gemcitabine cisplatin. If we talk about the secondary endpoint, overall survival, again it was not reached in both the arms, but the hazard ratio is showing that there is trend towards improvement with EV plus pembro arm. The 1 year and 2 year overall survival trends also show the similar thing. Even the subgroup analysis is showing more or less all the subgroups are doing better with EV plus pembro. If we talk about the second important secondary endpoint, that is PATH-CR rates, the PATH-CR rates were 55%, almost 56% with EV plus pembro versus 32% for gemcis. The difference between 23.4% in PATH-CR rates also with EV plus pembro. Out of those who underwent actually surgery, almost 66% did have pathological complete response in EV plus pembro arm, comparison to 36% in gemcis arm. Whenever we use EV, we are having some thoughts about more side effects. We have seen skin toxicities, peripheral neuropathies, more commonly it is in general thought to be not so much easily doable treatment. The same thing was seen here also with the side effects being 98% patients in both the groups actually had side effects. Grade 3 side effects were 75% in EV pembro group versus 65% in gemcis group. The serious treatment emergent adverse events were 63% versus 48%, and treatment leading to death were 2 in the EV arm and 1 in the gemcis arm. So if we look at the safety analysis in detail, the major side effects were skin related mainly, pruritus, alopecia, anemia, rash like this, which were more or less not grade 3, it were more commonly in grade 1 and 2. The grade 3 main side effects were anemia and urinary tract infections. If we talk about the major side effects during surgical phase, again anemia and other prostate cancer were the main side effects. The special interest side effects of EV were skin reactions and peripheral neuropathy. For chemo, we already know what are the major side effects that we come across. So the summary was EV plus Pembro significantly improved OS, EFS and PET-CR rates in comparison to gemcitabine cisplatin. So probably still we will be using gemcis more, but slowly there may be a place for EV in this space also. EV Pembro result is it the first ADC where you are not giving any chemotherapy and still getting very good pathological complete response. Based on EV 303 and 304, whether in cisplatin eligible or ineligible, both the groups EV plus Pembro has shown better outcomes in comparison to standard of care chemotherapy. So all MIBCs based on these results can be given actually EV plus Pembro irrespective of cisplatin eligibility or ineligibility. Yeah, thank you for your patient listening. Anything? Yeah.
Thank you. Thank you. So next we call upon Dr. Chakor Vora. He'll be discussing two abstracts, both of them primarily focusing on ctDNA guided response adapted bladder preservation in muscle invasive bladder cancer.
Okay. Yeah, good afternoon everyone. So I'll be discussing two studies, the RETAIN trial and the IMvigor 11. So the RETAIN trial is, both were discussed at the ASCO GU 2026 a month ago, and both are about the role of ctDNA guided response adapted bladder preservation or ctDNA guided adjuvant therapy. So bladder preservation, we know as more and more neoadjuvant protocols are being developed, there are almost 35 to 60% of patients who achieve pathological complete responses. And so, do we really need a cystectomy or radical cystectomy, or bladder preservation can be done? That needs to be looked into more and more details. So there are 3 to 4 studies where which have been completed and which have been looking for bladder sparing protocols of treatment. RETAIN 1 is one of them, and I'll be briefly presenting RETAIN 2 over here. So the RETAIN 2 looked at patients with an early disease T2, T3, ECOG 01, and the patients who underwent TURBT, so patients underwent TURBT, the samples were subjected to a mutation analysis to look for mutations in ATM, RB1 or ERCC2, and this was utilized later on for randomization for patient segregation. All the patients received 3 cycles of immunotherapy with nivolumab and chemotherapy, the MVAC protocol, and after 3 cycles, all the patients underwent evaluation with a mapping TURBT, a CT scan, and urine cytology, and also a ctDNA that I'll be mentioning later on. So the patients who had no residual disease post neoadjuvant chemoimmunotherapy and had a mutation positive in either of these genes were recruited into the active surveillance arm. Those who had no mutation or had any residual disease or positive urine cytology were advised to undergo one of the interventions of the patient and physician's choice. So the intervention could be intravesical therapy, chemoradiation, or cystectomy. And the primary endpoint of this trial was 2-year metastasis-free survival. So the the primary endpoint, and so 80 patients began with the study. Intention to treat analysis was done in 71 patients. 48 patients after neoadjuvant therapy underwent some or the other intervention. 22 underwent only active surveillance. So, and coming straight to the result, the metastasis-free survival in active surveillance arm as well as the intervention arm was almost the same, 82% and 85%. So a carefully selected patient on the basis of a mutation analysis, on basis of a CT scan, TURBT, a checked TURBT, and urine cytology can be advised active surveillance as per the results of the RETAIN 1 and RETAIN 2 trial. So this is what they are recommending. Coming to the ctDNA part, which is the main point of discussion from my side. So the RETAIN 1, the neoadjuvant treatment was only MVAC protocol. RETAIN 2, MVAC plus nivolumab was given. The ctDNA collection or ctDNA analysis was done at baseline, that is before the neoadjuvant therapy, at 3 months time point, or just post NAC, post neoadjuvant therapy, and then at 3 monthly intervals in the RETAIN 2. So that is when the ctDNA was analyzed. That is the number of patients who received cystectomy or chemoradiation or active surveillance, pooled analysis of RETAIN 1 plus 2. And if you see, out of the 42% of patients who had baseline ctDNA positive, only 13% were ctDNA positive after the neoadjuvant therapy. So 72% patients were converted from ctDNA positive to ctDNA negative with an effective neoadjuvant treatment. It may be only MVAC or MVAC plus nivolumab. So that's what RETAIN gives us, that a good neoadjuvant treatment, good protocol, a strong protocol can convert a ctDNA positive to ctDNA negative. Coming to the survivals based on ctDNA, so patients who were baseline ctDNA negative, almost 95% of them were metastasis free till this point of analysis, while ctDNA positive patients had a significant increase, the graphs show that yes, ctDNA positive patients were at a much higher risk of metastasis, of developing metastasis. And so that even the patients who got converted post neoadjuvant therapy, those who were still ctDNA negative, those are the ones who really did well as compared to those who remained ctDNA positive post neoadjuvant therapy. So does ctDNA affect prognostic? Is prognostic in overall population, whether they've undergone cystectomy or not, or like whether the DNA clears or not? The ctDNA negative throughout, from baseline till the end, they did the best. The ones who got a clearance, they definitely did better than those who could never clear the ctDNA post neoadjuvant therapy. So, and active surveillance versus cystectomy, the patients who were ctDNA negative to begin with, those patients had have had a equally good response or results. The ctDNA could predict systemic control, but could not predict local control. So 24-month metastasis-free survival was 82%, but 24-month recurrence-free survival, the local recurrence-free survival or recurrence-free survival was only 51%. So this suggests that ctDNA can, and as we expect it to, it can prevent or it can predict metastasis, but not local recurrence. So that's what we can understand from this one. Coming to the second presentation, can you run please? I think I need to be very quick with this. So this is another trial of ctDNA, of the exploratory analysis of ctDNA dynamics. The ctDNA testing was a very personalized way. The tumor DNA as well as the patient's normal DNA were analyzed, and a personalized tumor-informed assay was designed in this particular way. And so this is the exact way in which ctDNA probably should come into real practice also. The study design, I'll not go into it. We know that patients with ctDNA positive do worse, ctDNA negative do better. ctDNA dynamics, those who have an early ctDNA positivity, they also have a higher ctDNA concentration. And those who get a ctDNA positive later on during the following months, there the concentration was low. Does it correlate with the survivals? Yes, it does. Those who have an early or initial test ctDNA positive, there the median DFS was 6 months, median OS was 21 months. Those who had a delayed ctDNA positivity, there the median DFS almost double, median OS was 35 months, 1.5 times that of the, and similar trends are seen with the concentration. If the ctDNA concentration at diagnosis or at detection is high, the median DFS is just 5 months as compared to 12.2 with ctDNA low. And again, 21 months versus 35 months at the OS was seen. Is it a marker of response to therapy, response to treatment? Can it become beyond prognostic marker? Can it become a predictive marker? And can we plan our treatments on the basis of this particular test? So yes, it has been shown over here that the disease-free survival was in patients who had a complete clearance of their ctDNA on adjuvant treatment. So in this particular trial, it was atezolizumab. Let us say any adjuvant treatment, if they develop clearance of ctDNA, circulating tumor DNA, then their median DFS is not reached. That beautiful can be a marker to tell us that yes, you are doing good. You don't need to do anything else, just do this particular treatment. On the other hand, those who have an increase, a twofold increase in the ctDNA concentration, they are the worst performers, and those are the patients. So we can select which patient you can keep on only immunotherapy, which patient you should be adding chemotherapy or adding further other maybe some ADC or some particular treatment to improve the outcomes in this particular patients. So that's the beauty of this test, a blood test, but needs to be done at regular intervals, will have to be done in a cost-effective manner. Those are the limitations of this particular testing modality presently, but definitely this is what we want in oncology, a personalized approach, a patient-oriented or a very selected approach. Those who are negative, treat them less. Those who are positive, treat them more. So to conclude, serial ctDNA testing can differentiate patients with high or low risk of recurrence and avoid unnecessary adjuvant treatments post-cystectomy. Also, as has been shown in the retained trials, some patients can do off without cystectomy also. So you can select your patients. Our treatment protocols in future are likely to be integrating ctDNA as a very important component or very important treatment prognostic, treatment predictive marker also. Patients, we have seen already that the ctDNA timing and concentration conveyed additional prognostic information, and early ctDNA positivity and a high concentration of ctDNA is associated with a poorer or a shorter DFS and overall survival. Adjuvant treatments like atezolizumab promote ctDNA reduction and clearance, and these dynamics are associated. So clearance of ctDNA is associated with better disease-free survivals, at least as of now, and I'm quite confident that looking at these trends, we may get overall survival advantages also with the if we do the monitoring in a proper way. So with that, I conclude my talk. I thank you for your patient attention.
Next presentation is from Dr. Sudeep Das.
Thanks to the organizing team for having me here. So I'll be presenting the updated result of RC48C017 trial. Thanks to the organizer again for providing me the slides. And this is a phase 2 trial, small trial, but the result will be impactful because the patients they selected in these trials are unique. They are HER2 positive bladder cancer, muscle invasive bladder cancer who are HER2 positive. And my colleague Dr. Deep Bora showed that enfortumab vedotin, which is an ADC plus pembrolizumab, both can achieve a PAT-CR rate of 60%, and that is in the neoadjuvant and adjuvant setting. So this trial is neoadjuvant treatment with disitamab vedotin, which is an HER2-directed ADC, plus perioperative toripalimab in patients with muscle invasive bladder cancer who are expressing HER2. This is a phase 2 trial. So we know that cisplatin-based neoadjuvant chemotherapy is the standard. Recently, Niagara trial showed that if you add durvalumab in the perioperative part, then you achieve a not only PAT-CR improvement, but also overall survival benefit. Here, there are many trials which showed benefit of ADC. So in HER2 positive bladder cancer, particularly in metastatic setting, two ADCs like trastuzumab deruxtecan and disitamab vedotin both have shown efficacy in phase 2 trial, and that is in second line setting after progression on first line chemotherapy. But none of the anti-HER2 ADC is tested in non-metastatic setting. So this is the first trial showing such ADCs has usefulness in non-metastatic setting. The difference between in this strategy from the trial Dr. Deep Bora was showing that in that trial, the enfortumab vedotin, which has chemotherapy component because it is an ADC, was continued in adjuvant part also, but in this trial, the disitamab vedotin was given only in the preoperative setting, not in the adjuvant setting for whole 1 year. This is the trial design. So, and the patients who are any HER2 score positive, IHC 1+, 2+, 3+, please note all the patients were enrolled. The trial design was disitamab vedotin 2 mg per kg plus toripalimab 3 mg per kg Q2 weekly for 6 cycles, followed by radical cystectomy, then followed by toripalimab only was continued in the adjuvant setting for 20 cycles, that is full 1 year, but not the disitamab vedotin, the ADC part. The primary endpoints were pathological complete response. Secondary endpoints were pathological response rate defined as anything less than YPT1, event-free survival and overall survival and adverse events. So look at the baseline characteristics. Total number of patients were 47. Here to note that almost 25% patients, they had a creatinine clearance less than 60. Please note in Niagara trial, the GFR as low as up to 45 ml was also enrolled in that Niagara trial. Most of the patients were HER2 IHC2. So HER2 IHC2 were 57% patient were HER2 IHC2, HER2 IHC3 were 32%, even HER2 IHC1 was 10.6%. PDL1 score does not have any implication in treatment of bladder cancer, but still PDL1, most of the patients are PDL1 negative, 53%. Most of the patients were pure urothelial carcinoma, 76%. Some of the patients had some other differentiation too, like squamous or glandular or sarcomatoid type. Whether the pure urothelial carcinoma or urothelial carcinoma with mixed differentiation, they had similar results. Most of the patients with the PDL1 positive or negative, similar kind of PATCR rates, and most of the PATCR rates were observed in HER2 IHC3+ rather than IHC2+. Event-free survival, 12 months event-free survival 92.5%, 18 months event-free survival 86%, median event-free survival not reached. Event-free survival in ITT population, 18 months event-free survival 83%, 12 months overall survival, median overall survival not reached, but 1 year overall survival was very impressive, 96%. The post-operative complications. Most of the post-operative complications were grade 1 or grade 2. Hardly there were any grade 3 onwards post-operative complications. Now, treatment-related adverse events. Grade 3 onwards treatment-related adverse events were reported in 21% patients, and only 12.8% patients, they had serious adverse events. What are the most common treatment-related adverse events? Alopecia, transaminitis, asthenia, hypertriglyceridemia, loss of weight, and hyperglycemia. So to conclude, RC 48017, this is the first prospective study, though this is a phase 2 study, but this is a very impactful trial. First prospective study showing that ADC in combination with PD-1 inhibitor, in this case toripalimab, as perioperative treatment provided prominent outcomes in operable MIBC with a PATCR rate very impressive 63%, 12 months of event-free survival rate of 92%. Neoadjuvant DB plus toripalimab did not delay RC procedure or impact patient's ability to undergo RC. Safety profile was manageable with no new safety signals. The result indicated that neoadjuvant DB plus perioperative toripalimab had promising efficacy and acceptable safety in patients with HER2 expressing MIBC. Though the trial enrolled all HER2 comers like HER2 1+, 2+, or 3+, but most of the benefit was seen in HER2 3+ patients. With this, I want to thank you all. Thank you.
Thank you, Dr. Das. Dr. Vasanta Priya. SBRT, I think, protocol you are going to present. Yes.
Good afternoon all. I'll be presenting about Volga 2, which is a trial in progress. It is about role of SBRT in metastatic urothelial cancer and those who are progressing on maintenance therapy with avelumab. So the standard of care in this setting is platinum chemotherapy followed by maintenance avelumab. So in spite of being on this maintenance therapy, about 50% patients progress at a median of 5.5 months. So this oligoprogression with controlled systemic disease offers a therapeutic opportunity. So in electronic survey by the Bucare consisting of 72 oncologists, so about 71% agreed to go for SBRT for treating these lesions while continuing the same first-line systemic therapy, and 25% agreed to switch to a second-line therapy. So since yesterday we have been talking about MDT to the oligoprogressive lesions, I'm not gonna go in detail. So these oligoprogression offers localized resistance and opens up an ideal window for metastatic directed therapy. So this is a trial schema. So patients with metastatic urothelial cancer on avelumab maintenance with oligoprogression, they are randomized into two arms. In one arm, they are offered SBRT to these oligoprogressive lesions while being continued on avelumab maintenance. And in the second arm, they'll be switched to next line systemic therapy based on the physician's choice. The primary endpoint of this trial is 2-year overall survival. The secondary endpoints include median OS, PFS, SBRT response rates, and safety. So in the inclusion criteria, patients with less or equal to 5 lesions were included. So repeat SBRT is allowed in the trial if the interval between two radiation period was more than 4 months. And they have excluded patients with brain metastasis and spinal cord compression. So this is the statistical analysis. With the standard of care, patients get a 2-year overall survival of 45%. The investigators are quite ambitious and are aiming for a OS of 80% at 2 years. The false positive rate is 5% in this trial. So with Olga 2, it opens up a personalized management of urothelial cancer and offers a therapeutic window for MDT in this oligoprogressive setting. Thank you.
Thank you, doctor.
Next I call upon Dr. Deepanjali Patel, and she'll be presenting the phase 2 IndieBlade trial.
A very good afternoon. I'm Dr. Deepanjali Patel, Consultant Radiation Oncologist at Coquitlam Hospital, New Bombay. Thanks for having me here and giving me a chance to present this excellent study, which is talking about giving a potent systemic immunotherapy before consolidation chemoradiation therapy in the urothelial carcinoma of the bladder, giving an option of bladder preservation. Now, the current standard for the treatment is cystectomy, which is the surgery of removing the bladder entirely. But very few people get this chance of offering them a bladder preservation option. So the goal of the study is to broaden the population which can be offered bladder preservation. This study is actually the extension of the Nibuka trial, which talks about excellent pathological response after the same regimen which was given and increased progression-free survival, which was seen in the same patients, and they tried to incorporate the similar regimen in bladder preservation setting. Talking about the study design, it is a multi-center, single-arm phase 2 trial. The sample size was of 50 patients, and T2 to T4 diseases were taken. Also, the node-positive patients were included in the study. The primary endpoint was seen at the end of 2 years, and the primary endpoint was bladder intact, event-free survival. The event definitions were muscle invasive nodal distant recurrence, cystectomy, switch to chemo, or death. Secondary endpoints included the overall survival, protocol toxicity, and the ctDNA. Now coming to the treatment plan. The treatment plan was devised so that the ipilimumab was given on day 1. On day 22 was the combination of ipilimumab and nivolumab, and on day 43 was the nivolumab, which was induced. After a break of 10 to 12 weeks, which was given for reassessment, the patients were assessed for whether they are going for bladder preservation or for the surgery, or they had to be switched to chemotherapy. Patients who qualified were taken for concurrent chemoradiation therapy. A dose of 50 gray was given to the entire bladder and 60 gray boost to the tumor bed. Along with that, concurrent chemo was given in the form of 5-FU or capecitabine. So the study had very exclusive inclusion and exclusion trials. And if we were to give a profile of the patients, around 22 patients were T2 stage, T3 stage were 21 patients, and node-positive disease, 7 patients had node-positive disease. Around 90% of the total population of these patients qualified for the concurrent chemoradiation therapy. So coming to the primary endpoints, it was a remarkable success that was seen in the trial. 76% people showed bladder intact, event-free survival, which was targeted around 70%. Along with that, the secondary endpoint, 96% showed overall survival at the end of 2 years, with showed bladder intact, event-free survival. Around 90% patients were taken for concurrent chemoradiation therapy, that is bladder preservation. Along with that, ctDNA was taken as an important prognostic factor for this. Patients who were ctDNA negative at the baseline had a better chance of bladder preservation and bladder intact, event-free survival by the end of 2 years. So with this study, I think there is a bigger chance for increasing the scope of further clinical development when it comes to bladder preservation for these urothelial carcinoma patients of the bladder. And they can be given, a bigger population can be given the option of bladder preservation apart from basic cystectomy. Thank you.
Thank you. So for the last talk, I would like to call Dr. Seriesfor Karmarkar, and she's going to present the phase 3 Sunrise 2 trial.
Good afternoon, everyone. This is the last topic, and I have tried to keep it short and crisp so that everyone can enjoy their Sunday afternoon. So my topic is gemcitabine intravesical system, that is GEM-IDRS, in combination with sertralimab versus chemoradiation in muscle-invasive bladder cancer, which is the final results of Sunrise 2 trial. So before going into this, let us just see what is gemcitabine intravesical system. We know intravesical drug instillation is an important component of treatment in bladder cancer. However, there are several challenges to this. What are the challenges? Firstly, there is limited drug exposure because the drug, after 1 or 2 hours, it is voided. There is drug dilution, and also there is logistical challenges in repeated drug instillation. So what is the solution for this? The solution is to deliver a therapeutically active dose of medication directly into the patient's bladder in a sustained fashion while concomitantly avoiding systemic toxicities. This resulted into the innovation of the TAR-200 mechanism, that is the gemcitabine IDRS. Gemcitabine, due to its pharmacokinetics, is very suitable for this. So let us see what it is. It consists of a pretzel-shaped double lumen device in which the central lumen, as you can see, contains 225 milligram of gemcitabine mini tablets along with an osmotic agent, which is usually urea. The principle behind this is osmotic pump. It is inserted into the bladder with the help of a catheter, and after it is removed, the outer lumen has a very super elastic nitinol wire which helps in getting into the previous shape. The removal of this device is via cystoscopy. What is sertrelimab? It is an investigational immunotherapy drug which targets PD-1 given as an IV infusion, and it is being evaluated for various cancers. So the Sunrise-1 study had evaluated the role of TAR-200 in NMIBC patients. I won't go into the details of the study. There were 4 cohorts in this. It has shown that TAR-200 monotherapy was very well tolerated with high CR rate, durable responses, and prolonged DFS in BCG unresponsive high-risk NMIBC. And TAR-200 monotherapy also offered a favorable risk-benefit in BCG unresponsive CIS. The safety, tolerability, and efficacy of TAR-200 was also evaluated in MIBC. This study was a pilot phase 1 trial which evaluated 23 patients. They had included T2A, T3B, N0, N1 cancers who declined or were ineligible for cisplatin-based combination therapy. They had included both tumors, residual tumors with more than 3 cm after TURBT, and also patients who had undergone maximal TURBT. They found that the controlled intravesical gemcitabine release was safe, well tolerated in patients with MIBC. Now coming to the main study, that is the Sunrise-2 study. It is an open-label, multicentric, randomized phase 3 superiority study. It included patients of more than 18 years with CT2 to T4A, N0, M0, MIBC who declined or were ineligible for radical cystectomy. The patients were divided into arm 1 and arm 2. Arm 1 was the experimental arm, which consisted of gem-IDRS with intravenous CET. Gem-IDRS was given every 3 weeks for 18 weeks, followed by every 12 weeks until week 144, and CET was given 3 weekly until week 78. The arm 2 was the standard arm, which consisted of cisplatin or gemcitabine-based radiation to a dose of 64 or 55 gray over a duration of 6.5 weeks. The primary endpoint was bladder intact event-free survival, which was defined as time to muscle invasive or distant relapse or radical cystectomy or death. The secondary endpoints were overall response, which was confirmed either using biopsy or using imaging like CT MRI at week 18, metastasis-free survival, overall survival, and the safety. Coming to the results, 518 patients were randomized, with arm 1 having 262 and arm 2 having 256 patients, with a median follow-up of around 11 months. Gem-IDRS plus CET did not show superior bladder intact event-free survival over standard chemoradiation, and the 24-month rates were 58.5% versus 66.5%. At week 18, the overall response rate was 56.7% in arm 1 and 65% in arm 2. In the patients who had achieved a complete response at week 18, 24-month BIEFS were 76% and 72% respectively. This is a table showing the findings, which I have already told, and I won't go into the details of this. Coming to the toxicity profile, any grade toxicity treatment related seen in arm 1 was around 80% and in arm 2 was 88%. And grade 3 or more toxicity in arm 1 was around 27% and 32% in arm 2. The most common grade 3 toxicity in the arm 1 was urinary tract infection, and in arm 2 it was neutropenia. There was no treatment related death in either arm. So to conclude, in Sunrise-2, Gem-IDRS plus CET did not show superior BIEFS over standard chemoradiation patients in MIBC patients who did not receive radical cystectomy. The 24-month bladder intact event-free survival rates in patients who had achieved complete response in week 18, the metastasis-free survival and the overall survival rates in all patients were similar in both arms, and there were no unexpected safety findings in either arm. If we do a SWOT analysis of this trial, the strengths of this study was it was a phase 3 randomized multicentric rather multi-continental trial. It has taken into account both local chemotherapy along with systemic immunotherapy, thus addressing the issue of both local and systemic control. It has incorporated bladder preserving strategy, and also the study really had a large number of patients. The weaknesses were the trial was stopped due to futility, and so the long-term efficacy and the safety is not known. The opportunities are that it has shown really promising results in NMIBC, so alternate drug or immunotherapy combinations with this may be evaluated. The threats is that the failure at phase 3 may shift the focus away from MIBC. Thank you.
A few comments about the three of these papers related to radiation and conservation therapies. One is Dr. Vasantapriya talking on SBRT. I hope in general, oligomets and SBRT has been quite a successful thing as of today in various malignancies. I hope we'll wait for the results of Volga 2 to come. But much more interesting was this Mrs. Dr. Deepanjali Patel's presentation on 90% local control rate, 90% event-free bladder preserving event-free survival. That is very interesting. And phase 3, as of today, being an invasive and futile, I don't think there is any further application of that. And much more than that, I am interested from medical oncology group. As of today, ctDNA, how commonly people employ in a metastatic or a patient who has been having a mets which has been controlled, how commonly you use a therapy when there is only ctDNA positive?
So ctDNA is actually, if you see for the adjuvant, it is established, sir. If the ctDNA is negative, you can easily avoid adjuvant atezolizumab as well as adjuvant nivolumab. The ctDNA is also coming in for the Niagara trial where perioperative durva was given, but unfortunately the trial when they started, they did not differentiate between neoadjuvant and adjuvant, though it also shows that if the ctDNA is negative post NACT and cystectomy, there may not be much role of adjuvant durva, but that cannot be proven because the trial design was very different. But for adjuvant atezo, there was no benefit, and for adjuvant nivo, there is no benefit if your ctDNA is negative. Though it is not in the guidelines, but it is very clear in the practice that if post-cystectomy your ctDNA is negative, then you may not give any adjuvant immunotherapies.
Your point is taken. It is not in the guidelines, but when it is positive, do you use it presently, any drugs for that?
We cannot, escalation and de-escalation right now, no. De-escalation, yes, as I told, but escalation, there is no study which we are doing. De-escalate in adjuvant, we will do it. For adjuvant immuno.
Yeah, thank you. The same question I wanted to know what is the cost of doing ctDNA and how frequently you do it?
Actually, that is a more difficult question. The approximate cost is around 1.2, but how frequently you do it, if you go by the trials, they do it pre-analysis, then they do it after. Ideally, the analysis is done after 4 weeks and then every 3 to 6 monthly till 1 year. So that becomes a pain. It is not one way but ideally, if I have to decide, it will be, if I have to do it in my practice, will be after 4 weeks or 6 weeks of cystectomy, and then at least one value 6 monthly and one more. That is, but otherwise it is 3 monthly ideally.
So which one you prefer, ctDNA or CTC?
CTC and ctDNA is, the apt question will be that what is the ideal ctDNA, whether you do a tumor informed or a tumor agnostic. The tumor-informed ctDNA is that they will take the same patient's tissue biopsy, the bladder specimen, and they will run the NGS on that. And once they have the genetic information from the patient's biopsy or from the bladder tumor, they will run it on the blood. This is tumor-informed. This is what the Signatera does it, and this is what the Niagara has done it, and the bladder is more the tumor-informed way. The second is tumor-agnostic. That is irrespective of that. They do it on the genomics. But if you want to ask me, it is more to do, for the bladder, it is to be done tumor-informed. And Signatera is one of the approved assays to be done.
Thank you. I think even all the abstract what they have presented, so you can see that there's a lot of space for neoadjuvant and adjuvant immunotherapy roles. I think we are expanding on that. I think Dr. Deep Vora is here. Yeah, he's here. So now we have Durva, we have EV Pembro for cisplat eligible patients. although it's not yet come in the guidelines, which one you choose for your patients? Because we have to, earlier it was only one Durval, now it's EV Pembro also. So which one you are comfortable as a medical oncologist to give? Because the results looks the same.
We are more comfortable so far with immunotherapies alone. We have used a lot in past. Our experience is much better with immunotherapy alone. So as of now, still the time we are not using EV so commonly, things will be more towards durvalumab probably. But more and more we use ADCs, we will be more experienced with that and things might change.
So for the radiation onco, Dr. Deepanjali, if you see your trial study, so there are 7 patients with lymph node positive. Your radiation include only bladder and the boost to the tumor base, but not the lymph nodes. So it's a standard practice that we do remove the lymph nodes in surgery, but why the trial didn't include any radiation to the pelvic nodes, even if it is negative on imaging?
So in the regular practice, we include the regional lymph node irradiation, but I think the trial excluded, it was only focusing on the bladder. So
it makes sense even for the trial, because we want the answer from the trials. If they exclude pelvic nodes, again one question will be raised. So what was the reason they didn't include? No, I think bladder may not be including your external iliac. It may be including internal iliac, but not external iliac.
In the NCDB analysis, it was shown that it covers the external area, but provided you're giving a 1.5 centimeter margin. Therefore, a trial was done comparing in the previous session. Yes, it does show that WPRT does, but the failure being less than 10% and the external iliac was covered, and that has been shown in the NCDB.
No, but in this trial, I think they have not covered anything in the lymph node area. What the one you presented?
separately, they haven't covered the regional lymph node irradiation.
Okay, thank you.
US always include pelvic lymph nodes, but when it comes to Europe, they don't include, because according to them, by giving just 1.5 centimeter around bladder would cover more than 70% of the lymph nodes, and the pelvic failures is less than 10% when they have not included pelvic lymph nodes. It is the same, more or less analogous like with the prostate alone versus pelvic RT, but that has been settled with the POP RT trial. Yes.
But even then, as you know, we know that when you see the anatomy, I think 1.5 centimeter may not cover the lymph nodes at all. That is our assumption, just because patients don't fail.
Now,
So less than 10% failure in lymph node is also a very high figure. So I think if US is giving, if somebody is not giving, I don't know the logic behind that. Because if somebody says from an international level, we have to do lymph node dissection up to common iliac for a CA bladder, and it applies all over the world. So I don't know how to explain and substantiate the results. It's fine. No issues.
Now international consensus, bladder consensus guidelines recommend to include pelvic lymph nodes.
Finally, they are come.
Yes. Lastly, some comments from the medical oncology perspective and some to answer the questions which were asked by my colleagues. So with EV304, so it's interesting that the control arm was only chemo. We all agree that chemo plus durvalumab would have been a fair comparison, but I do agree the Genesis is also a good comparator arm. But looking roughly at the numbers, PCR rates in the rate of 55 to 60% as compared to 37% with the Niagara study, and some numbers for the 2-year EFS, 77 to 79% for EV plus Pembro as compared to 70% for the Niagara. Some numerical benefit, yes. Secondly, in a fit patient eligible for enfortumab plus vedotin who's fulfilling all the criteria, yes. But what is important to know is that only 50 to 60% do complete the protocol defined criteria of 4 neoadjuvant plus 5 adjuvant. That is 6 months total duration of EV and 1 year total of immunotherapy. That is important. In the prior moderation in the panel, we were discussing that most of these neoadjuvant have PCR as the endpoints. This is one of the study which has EFS as an endpoint, so good endpoint for a neoadjuvant trial. Secondly, for the ctDNA. So I do agree that the prices can vary for the ctDNA testing. In our institute, we do it at around 20 to 25,000. I do agree that the time points are important. It has to be baseline, post-neoadjuvant therapy, post-surgery, and then 3 monthly subsequently. It has to be done in a cost-effective manner. But it's important to know that all of this is being done in adjuvant therapy eligible patients. So supposing not received any cisplatin therapy, T3 and above, node positive, they definitely do warrant some form of adjuvant therapy. that can be gemcitabine platinum or nivolumab, or in a ctDNA positive patient, atezolizumab. So in a patient who is eligible to receive adjuvant therapy, something should be given. So as per the IM Vigor or the Checkmate 274 or chemotherapy. For Dr. Sudeep sir's study, it will be very interesting to see how many proportion of patients in the EV Pembro and in the Niagara do have this HER2 positive subset, and whatever their outcomes is compared to disitumab vedotin plus Pembro. But a good way that ADC plus Pembro and ADC plus immunotherapy is paving the way for subsequent neoadjuvant bladder trials. Thank you.
Any institution presently doing a trimodality along with immunotherapy? Okay.
So thank you, respected chairperson, sir, for moderating such a wonderful session. Now we are coming the last session, which is very, very interesting, and this is none other than a panel discussion on the F6%. So to do the honors, it's a great pleasure to welcome and invite Dr. Sachin Trivedi, sir, on the dais, and I request Sachin, sir, to introduce the panelists, please, on the dais, please.
So good afternoon, everyone, and I'm not very envious of anyone because this is the last session. I know everyone is waiting to go for lunch and go home, but see, my job has been made very easy by our panelists before and by our chairperson, because they've gone through the details of the articles already. We'll just go into the depth, and to discuss all these findings and where we go for future, I'd like to invite my panel. So may I ask Dr. Chopre to join us on the stage, please? Dr. Deepak Dangwal, Dr. Pranav Chadha, Dr. Rohit Pai, Dr. Darshana Rane, Dr. Samir Srirangwar, Dr. Vishnu Hari, Dr. Kritika, okay, so we've got a full house. Now, the way we can do it is just go article by article and see things out, or we just have an open discussion. But I think we'll just do a mix of both, and please feel free to chip in, because whatever the expert comments were made by our chairpersons, they were really the highlight of where we are currently and where we are heading to. Okay. Now we don't have a uro-oncologist, Dr. T.B. Uraja. When he was here, he always used to chip in. But do we have a urologist or uro-oncologist? Yeah, so please feel free to chip in. Now, let me ignore all the findings here. Let me try to set the stage from the surgical and uro-oncology point of view and from radiation oncology point of view. How often do you see patients who you think of offering neoadjuvant systemic therapy or neoadjuvant therapy to begin with, or how many people ask about it? Is there any consensus? Is there any pattern to it? Because we as medical oncology, by the time they come to see us, we are in a place where they are already with an advanced disease or they have metastatic disease. So, Dr. Deepak, maybe you can comment on this.
We usually give NSCD to all patients.
To all patients?
Yeah. If there is a survival advantage with cisplatin 5%, so we tend to give.
Okay.
Muscle invasive, muscle invasive.
Muscle
Those who are
invasive.
going for bladder preservation or cystectomy.
Okay.
What about variant histologies? What do you do for those? Variant histologies.
Yeah, so squamous and adeno, there is no data for bladder preservation, so we directly go for CTRT or cystectomy.
Rohit, if that was the case, should we not be seeing more patients who the medical oncologists are offering neoadjuvant therapy? Do you actually see that reflects in the real world practice?
So I think if we talk about institutional practices where there is an MDT, probably muscle invasive bladder cancer would go for NACT. In real world, probably I think might be we are getting around 50 to 60% only, which are coming to us probably for NACT, so as to speak.
So one issue that we find sometimes as medical oncologists is that a lot of patients are afraid of all these toxic therapy, and they say, "Doctor, yaar, please surgery karke nikal do. Mujhe bas, I want to get rid of it." Do you encounter that in your practice?
One third of our patients decline to take.
Decline to take.
Decline to take. The other thing is we don't have equipoise about T2 disease. So T3 onwards, we completely agree we should have systemic therapy. In T2, it's mostly overkill.
Okay. And Sunil, in your opinion, have you had any instances where you have offered neoadjuvant GEMSIS and patient has declined, and what was the rationale and reason behind it?
I would like, I will discuss NACT for all the muscle invasive bladder cancers who come to me. Patient has not declined, but yes, twice or thrice I offered Niagara Durva plus GEMSIS, but I could not deliver it. The reasons may be something different. But yes, if the patient is being discussed in MDT, we would put it forward to consider NACT in all MIBC patients.
Okay. So, see, we all agree that, when you are able to offer neoadjuvant systemic therapy, the outcomes are much improved. And the ultimate aim here is not just only, well, it is to cure disease, but at the same time to also maintain the bladder function and maintain that kind of thing. You don't go for an extensive surgery. Samir, LBA637 that Dr. Dipanjali presented is offering something different where you might be able to escape those arguments of the toxicities and stuff. What is your thought on that combination?
Nivo-EP trial.
Nivo-EP.
So I think, sir, what I have seen in my practice many times, we start the discussion with like this is the muscle invasive bladder cancer. You need to take neoadjuvant. You need to go for surgery. And once we start the therapy, patients symptomatically get better. Their hematuria goes out. Their urinary symptoms resolves. And when the time comes, we consult for the patient for the surgery. They start saying, "No, we don't want to get surgery now. We don't want to get the bladder out." So many times they start with mindset, they'll go for surgery. But once their symptom improves, many times they decline surgery. So this is a very common scenario, at least at our place. So in that case, then we have to go for CTRT.
Okay.
Because the patient is not willing. So I think that bladder preservation strategy is going to come up. It is already there, but I think more and more patients will go for that kind of approach rather than cystectomy in future.
Kritika, any comment on the, because the results look quite good, very good actually.
One, it is a single arm study, and two, the patient number is I think just 50 in that. So we need to look into it more further because we cannot conclude anything by that trial as of now. And two, why to go with dual IO in the frontline setting and expose patient to everything straight up front, rather than keeping it chemo plus IO or single IO, something else. So I'm not very impressed.
So sir, with Nivo, EV Pembro, the PAT-CR rate is almost more than 50%. So in a case like where we have done a scan, there is no disease. We have done a scopy, there is no disease. Even we take biopsy, there is no disease. In that case, if the patient is even not willing for like surgery, so maybe like RT only is the option.
Okay. Dr. Vishnu, do you agree with Kritika to actually decide if you have too many options, you want to use one at a time?
Sir, as of now, I would not consider the study neoadjuvant dual immuno because it is a phase 1 trial, phase 1 or 2 actually. It is a hypothesis generating trial only. I would wait for a formal phase 3 trial before starting my practice. I would go with the category 1 recommendation as of today. I would advise my patient to go for chemo plus minus durvalumab.
Yeah, but you're right. I think most of us might not accept it, but this is actually opening new doors and new options, Dr. Pranav.
Preservation rates.
Yes, sir. For selected
Dr.
patients,
Pranav.
definitely.
The bladder preservation rate was quite impressive. You
Quite
know the
good.
number, yes, look at the 2 year. So it opens the door definitely for cisplatin ineligible patients. I think it makes sense.
And tell me, Dr. Pranav and Dr. Deepak, CTRT, okay, is this a replacement to surgery?
Yes, it can.
It is?
Yes.
And the outcomes are comparable?
Yes. So there has never been a randomized trial comparing a neoadjuvant chemo surgery versus CTRT. Let me be very clear and be honest. There has been no randomized trial. All this has been based on historical controls. Now we are comparing radiation which is 20 years back.
Yeah.
You look at 3DC as the systematic review in the previous session. We are not looking into the higher techniques, but when we are comparing it, we were comparing it with the robotic options. We were comparing it even with laparoscopic surgical options. So there has been no RCT.
Okay. Appropriately
That would
selected
be,
patients.
yeah.
It's a good replacement for surgery.
So I think, sir, T2, early T3 looks okay, but for advanced T3, T4 or N+, I think we are still for surgery. But I think more and more good neoadjuvant data is coming up. I think that in that scenario also we may start thinking of bladder preservation.
Okay. Now, do you have any difference in thoughts or any opinion on whether CTRT can replace surgery for this very early type of disease, or depending on the stage if we do careful selection?
Yeah, sure. We also want to preserve bladders wherever we
Yes.
can. And we do partial cystectomies even in T2 if it's in a diverticulum and dome or whatever. So I practiced in UK till February. In UK, it is offered as an equal option. In India, it is more physician-driven choice. It's quite different in India.
Okay, so now that brings me to the interesting question of the ctDNA. Okay, now the patient and many of us, our colleagues, are of the mind that if you haven't removed it, how do you know it has gone completely? Because at least in surgery, you've got good margins, and I know radiotherapy will also fry everything that comes in its way. But it is about the margin, because you are preserving some of the tissue behind the tumor or maybe around the tumor. Does anyone have any opinion on what role the ctDNA is going to play in this setting where you have given the therapy and you want to see if you have actually achieved complete path response? Kritika, maybe you are the...
So, as of now, I haven't seen any trial in which ctDNA has been done in this scenario, post-RT seeing the response. Whatever we are seeing till now, ctDNA, it's in the post-surgical, like adjuvant setting only, whether in bladder or whether in colon. So, like right now, I will not comment anything upon it.
So, Rohit, as proof of concept, do you think it will be a good idea?
So, I think we think that we may consider, but the issue is that if you are preserving the bladder and the ctDNA is negative, one single measurement is not going to help. You are going to monitor.
Yeah.
Suppose the ctDNA starts increasing. Do we offer cystectomy then in an irradiated bladder, or do we give systemic therapy? So, sir, we do the test which has implications on our practice, right? We just cannot keep on doing the test. So, even if hypothetically we do the test, how would we approach? I don't know.
Yeah. So, we have...
Can I, because in UK, like I said, we offer bladder preservation as an equal. So I have experience with following these patients up. Please do an MRI and a cystoscopy. This is good enough. If it was really T2, if ctDNA, you can do, it's not routinely done.
So again, I sort of agree, because we should not do these tests in this.
Even there is a urinary ctDNA concept coming up.
So, see, I'll tell you, we had a discussion about CTC versus ctDNA. So, yesterday we were all in a different conference and we were discussing about this in a separate workshop. So, CTC methodology currently is not as reliable as the ctDNA tech is. So the CTCs that we see are actually only p-CTC, which is a possible or a probable CTC. So ctDNA has a more, kind of concordance with the actual presence of disease rather than CTC. Having said that, you're talking about urine CTC.
Local.
But basically that is what it's a different type of urine cytology. How many of us, have you used urine cytology in any of the patient post-bladder preservation?
We are doing it in follow-up, I'm doing.
So I actually, we are not, and my thought is that somehow that you want to make a comment.
Urine cytology post-radiation is often inconclusive. The pathologist, it's always says atypical.
Is it is always?
It often comes as atypical cells, post-radiated bladder.
Hmm.
The cytology is very confusing to interpret.
No, but is
It's
it always
in guidelines.
atypical?
Huh?
It's in guidelines.
Yeah, you do it, but it will come as, you will have to more explanation.
No, but is it always atypical?
No, not
Dr.
always.
Vishnu?
Sir, I feel that all these CTC, imaging, cystoscopy and urine cytology, these are all complementary. We can't make a decision based on a CTC alone or a cystoscopy finding alone. So CTC is more kind of predictive of a metastatic recurrence, and for local recurrence, it is always local.
So see, that is where we are today. But the question or the very interesting trend that we are seeing is that CTC and ctDNA are going to be increasingly used as decision-making tools, like we have seen in other tumor types, and especially in bladder. Several of these trials that we actually see here have used this to decide or tell us or prognosticate for that matter and de-escalate. Now they don't allow us to actually decide on escalation strategies, and the problem is a lot of these trials, like we discussed yesterday, are coming from European countries where there is an inherent bias towards de-escalation. I would not say bias, but that is what the cluster of trials would show us. So do we imagine a time where, to build confidence for the patient, if you have a patient who have been offered neoadjuvant bladder preservation, CTRT, CTC negative, ctDNA negative, maybe in future when we are better equipped with our tech and understanding better sensitivity and specificity, we might be able to help us decide on this. I know, Rohit, this trial, the Tambola trial, the CT-guided immunotherapy following radical cystectomy. What would you take away from that?
Quite frankly, sir, I think post-surgery, I think at least there is reasonable data to suggest that we should give certain adjuvant treatment if the ctDNA is positive. I think ctDNA is clearly prognostic. I think post-surgery for clearly prognostic, I think there is a stark difference in outcome. And if we are monitoring it dynamically, for example, for 9 months or a year, which was done even in the IMvigor 011, probably the increase in ctDNA or detection of ctDNA should trigger the administration of immunotherapy. And I agree with sort of using ctDNA as a marker. In the IMvigor 011, for example, the people who did not, like I think 760 patients, or almost 250 were randomized in the end, but the rest 350 which were ctDNA negative, the outcome is superb. I think it's more than 90% survival, around 85-90% event-free survival over 2 years. So I think it is clearly prognostic, and this can be used as a trigger for post neoadjuvant treatment or post-surgery, post-neoadjuvant chemo, post-surgery treatment as an adjuvant immunotherapy.
Darshana, do you have any experience of using ctDNA in bladder cancer, CTC or ctDNA for decision making or?
I personally have never used ctDNA because basically the standardization has not yet there. And secondly, most of the muscle invasive bladder cancers are the aggressive ones which we overtreat any which ways. So there has been no clinical role for me as of now.
But the issue is that most of our labs are tumor informed rather than, tumor agnostic rather than tumor informed.
Yeah.
So we need to go for tumor informed ctDNA.
And we were discussing about the cost. Actually, the cost of ctDNA has come down dramatically. What does anyone have a figure in their mind what the cost is in Bombay?
Sir, actually the test which they have used, Signature, is around 2.5 lakhs. But we can... Yeah, but subsequently also I think 1.2 lakhs. The other test which is available in India is the garden one, reveal. That is also actually costly, one plus 1.5 lakhs. Generic labs are also doing actually, like Dattar are doing,
So
but
yeah, so
we
the
don't
Indian
know
companies are much cheaper, but they've not been used in the trial. So any of the medical oncology colleague has any experience of using EV, metastatic setting?
Yes.
What is your experience with EV?
Sir, actually it is a very good drug.
Yeah.
Actually, I think it is the way forward in bladder. That is
So-
the like game changer in bladder, I would say.
Absolutely. So I have got, I was really fascinated by the, the rapid result that I got for one of my first patients on EV. He's doing excellent. Now, that brings us to the ADCs. So, in the HER2 positive space, we were all excited that, this is a drug that will be tumor agnostic regardless of where the HER2 is, we'll be able to target this. This trial on dasatinib, vedotin, and toripalimab. Do you want to make? Does any medical oncology want to make a comment on a new ADC?
Sir, there has been previous data also on this DV drug specifically. One, it is including IHC 1, 2, 3, everything positive in that trial.
Yeah.
So basically, what we have to look when we are looking at the IHC, that is one question, and when we have to start the patient on DV. Then there is no, like we were using TDXD, there is some data in NCCN also about it. So whether we should go ahead with TDXD alone or this plus toripalimab, that is like another thing.
Actually, we have phase 3 evidence in MIBC for disitamab vedotin plus toripalimab. It was published last year in NEJM. But the problem is it is a Chinese molecule. And the whole population, 100% of the patients were from China.
Sunil?
And it has got an OS advantage also.
It does show the effective results, but like first question is inclusion of the HER2 testing. That is one confusing point, whether we should use it or not. And as of now, not convinced to use it, but let's see.
Okay. So, see, I have not used HER2 target therapy for bladder cancer in so far, but I'm sure if there's a patient who comes and we have exhausted EV and other things, I will be, willing to offer them N-HER2 or TDXD or whatever I can. And if this is available, maybe that, because that is a third, fourth, fifth line. You might have to try whatever you get access.
It's in a pan tumor to had, I think, 30-40 patients of bladder cancer. And it has shown almost 50-60% response rate with
Yeah.
TDXD.
Okay. Pan tumor. Okay. Now let me bring back. Hmm. Hmm. So this is where it is going to be personalization. So the question is, if you are going to give systemic therapy before radiotherapy. Yeah.
So that was the abstract that Nivo EP was given as a pre-specified manner in a bladder preservation. CTRT versus NSCT followed by CTRT.
So
Yes, start with.
Maximal TORBT followed by chemoradiation or maximal TORBT induction neoadjuvant chemotherapy followed by chemoradiation?
Second one.
We
So if you go with Marsden, they I think would follow the first one. In Imperial, we would do maximum TURBT induction, cystoscopy again, re-TURBT again, if necessary, go on and then complete. If there is any disease remaining in the mid TURBT, then you would probably not continue.
Sir, actually,
But
we
see,
don't
I'll
have.
tell you. So what?
We don't have any data for chemo NICT followed by CTRT or giving adjuvant chemo after completion of CTRT. We don't have any data. Nobody
There is
knows.
no data for that.
The standard practice in US is to go for CTRT alone with chemotherapy, cisplatin based, no chemo. But the problem is how to take care of the systemic disease. So
But CTRT is not for all patients. We have to select the patient properly. It's
Yeah.
not for node positive, it's not for advanced.
Yeah.
So
For
now let's
extensive
see.
CAS,
Now
hydronephrosis.
let's see. Let's set our goals very clear. What we want to do ultimately is to cure the patient with minimal damage. Okay. Now, if CTRT is a very good treatment available at the minute, but there are some residual problems. It is not completely like it's not going to be, the life is not going to be normal forever after that, right? There is going to be something. Now the question is to maintain that quality of life, if you're curing the patient and they're going to live for next 15, 20 years, what are our options? We have exhausted all local therapy options by doing surgery, extensive surgery, by doing CTRT. My thought is the answer is going to come through use of systemic therapy in some shape or form, either before, during, or after. What we have used in CTRT, that regime is a very ancient regime, and we were doing that for lack of anything available so far. Now the fact is we don't know who will benefit, how much they will benefit, and how confident can we be that they are going to be benefited. Other thing is also, my thought is that possibly immunotherapy is going to be the option there because it does not have any confounding or overlapping toxicities, doesn't hamper the CTRT. We have seen that in head and neck also, though the results were not as encouraging that we thought they would be. But that is possibly where we are going. Now, in interest of time, just last 2 minutes from our radiation oncology colleague, and then we'll make one final comment from all of you. So Dr. Deepak and Dr. Pranav, that trial on SBRT to the oligometastatic disease. I find it very exciting because we do that kind of thing for many other tumor types. There are certain tumor types where there are hardly any systemic therapy and the option is default if you got oligometastatic, just resect it or do something about it. How often do you practice this? Is this a standard practice or you still have to debate?
In breast, prostate, and lung, we follow the oligometastatic principle.
Yeah.
In bladder, the results
With
probably
this.
will help us.
And you're happy with the outcomes and
The only thing was that brain metastasis is considered as an exclusion criteria. Maybe 1 or 2 brain lesions could have been there. Cord compression, yes, we cannot do SBRT to the spine, but maybe brain metastasis. I was just thinking. But bladder, as of now, no. Breast, prostate, and lung. These are the 3 sites.
yeah. So I think even in bladder, if the data is encouraging, I think we would be willing to try because see after a couple of lines we are again in that zone where we don't know what to do. Got any other thoughts?
So Aaron trial has shown benefit in the urothelial metastatic. SBRT shows survival advantage also compared to this.
So excellent. So this is a question that we get frequently asked on our lung panels, on our breast panels.
The incidence of bladder cancer anyway is very rare. So it's not as common as breast and lung and others. So we tend to
That's
do more
true.
of breast and lung and other sites.
No, that's true. But now see, I'll request all of you to make just 20-second comment each, and then I'll conclude because we've run out of time. So you can start with Samir. Anything that you like in particular from all of these? Any of your star?
So I think, sir, whatever we are going ahead with data available, it is going to be more and more neoadjuvant therapies. I think more and more bladder preservation protocol will come in. We were discussing like only for T2 and T3, but now with good neoadjuvant options available, even advanced cases can be considered for maybe later on with the bladder preservation protocol. With ctDNA will definitely help us to decide the maintenance therapy or what modality needs to be chosen, or that is definitely in a way it will help us to decide the protocol and the maintenance therapy and the follow-up also. So I think all these things are coming up together in a very nice way, and I think next 3 to 5 years, we'll be in a better position to decide which patient needs to be treated in which manner. And I think patient needs to be first asked for whether they are willing for cystectomy or not. That should be the first point of discussion.
Okay,
Accordingly, we can always decide our.
Okay, very quick comment, Sunil. A quick one.
EV and immunotherapy combinations in NSCT has excellent results. So where to place ctDNA after when we give that combination as a NSCT?
Right.
I think EV Pembro is the way to go probably for muscle invasive bladder cancer as well as metastatic disease. I think this regimen will stay for the next couple of years at least. And I think bladder preservation protocols, last comment, is a work in progress. I think we need to first be sure ourselves what are we going to offer to the patients.
I think with neoadjuvant immuno, we will be able to de-escalate the radiation doses. So that, as you said, the quality of life after bladder surgery should be better. So maybe immunotherapy can come into picture in neoadjuvant setup so that we can reduce the radiation doses.
Okay.
So EV Pembro, as my colleague said, definitely is a way forward. Maybe ctDNA can be used to escalate the therapy in those who are still positive despite EV Pembro or other agents. My question also is, how many people use the multi-gene panel to decide their therapy? So that I would like to know.
My feeling is that EV Pembro, but we should include, I think ctDNA will come in deciding whether we should continue adjuvant EV Pembro in the setting, because most of the, majority of the patient, a large number of the patient could not complete the pre-planned adjuvant treatment. So if the patient is becoming ctDNA negative, then we can de-escalate the treatment in those patients also. So EV Pembro plus ctDNA monitoring, I think that will be the way forward. And one more thing is HER2 in this thing, in bladder, HER2 positivity. So I think Astra might be thinking about like TDXT plus minus durvalumab in this setting. I think it will also come up in bladder.
Sir, all said and done, everyone has discussed the hero here, that is EV Pembro. The thought-provoking part is that cisplatin ineligible, it was fine. Cisplatin eligible also now they are giving. So where does Niagara versus this keynote B15 lands up, that we have to see.
I would say on a philosophical note, the future has become too bright, it might blind us, so we need to be careful.
But
either you don't see or you get too much of light, so it might blind you.
I'd rather wear dark sunglasses in a bright, in a bright future than.
Can I ask one question? So what happened to DDMVAC? It was never a comparator. We gave it up completely.
Interesting. I have used DDMVAC with lot of hesitation.
And good result. We had decent PCR rates.
So DDMVAC Vesper study, I think the PCR rates reached up to 42%. So with DDMVAC alone, and so it's a good regimen. I myself hesitate to use it in private practice. I'll be very clear. But I think they were planning Niagara 2 with Durva and MVAC. But with this EV Pembro, probably they will shelve the plan.
I think that is something we can keep in our back pocket, because there are some more exciting stuff that is happening. But DDMVAC is a very valid and a very excellent, a combination. So, see, ladies and gentlemen, I think from those days of just being able to offer surgery or radiotherapy or platinum only, and the discussion was, should we use gemcitabine as a companion for CTRT? Should we use cisplatin? Or how can carboplatin be inferior to cisplatin where it is working? So from there, we have suddenly moved to a different level of discussion about ctDNA, immunotherapy, ADCs. And what we are seeing is a real manifestation of all those lab work that was being done for ages. So I remember, when immunotherapy had become a standard of care for melanoma and RCC. That was the first two disease sites. So the projection was, can we use it, can we replicate? And the discussion was, it is not necessary that it will replicate. And one of the trials that we were running in Birmingham was on use of Pembro in bladder cancer. From those days to suddenly having a plethora of immunotherapy, ADCs, everything seems to be having some role. And I think the secret is going to be in that assessment of the genomic makeup, exosome makeup, understanding the biology, and using this, and all these drugs will find their own niche. So hopefully when we meet again next year, we will have some more mature data on this. So thank you so much. Thank you.
A final good afternoon to everyone. I am here for the thank you note. So it gives me immense pleasure. So a long one has been given to me to read. So it gives me immense pleasure to deliver this closing remarks for the enriching and academically stimulating conference. Over the past 2 days, we have witnessed a remarkable exchange of knowledge with over 60 plus abstracts presented and discussed across a wide spectrum of genitourinary oncology. The depth of scientific content combined with the highly engaging and insightful panel discussions has truly enriched the learning experience and fostered meaningful dialogue among experts, among you all. I would like to extend my sincere gratitude to our esteemed patrons, Dr. Kumar Prabhash and Dr. Vinita Norona, for their guidance, encouragement, and unwavering support in shaping this academic platform. My heartfelt thanks to the organizing secretaries, Dr. Randeep Singh. Sir had a flight, so he had to move. Dr. Puneet Aluwalia and Dr. Aditi Agarwal, ma'am. And the co-organizing secretaries, Dr. Akhil Kapoor, Dr. Nandini Menon, Dr. Ritika Harjani, Dr. Saurav Patil, and Dr. Vivek, for their leadership, vision, and meticulous efforts in bringing together such a comprehensive and impactful program. Your dedication and coordination have been instrumental in the seamless execution of this conference. A special word of thanks to all our esteemed speakers, moderators, and panelists. Without for your time, commitment, and willingness to share not just data, but also your personal clinical experience, critical insights, and practical perspectives have been truly invaluable. I thank all of you for the enthusiastic involvement which has truly made this conference engaging and meaningful. I would also like to thank our pharma colleagues and industry partners for their continued support and collaboration in advancing academic initiatives like these. With that, we conclude this edition of Knowledge Series. We look forward to continuing this journey of learning, collaboration, and excellence in the future. Thank you all once again, and I wish you a safe journey ahead. Enjoy your rest of the Sunday. Thank you.